Assalamu alaikum, dear colleagues, friends, and professors. We are happy to welcome you in our third version of Enthesitis Summit for the third year. This year, we have a very rich program as usual. Today, we have 5 eminent speakers. We will cover almost all the aspects of enthesitis, from the pathophysiology, treatment targets, the identification in both arms for ultrasound assessment and scoring, and on the other hand, also assessment and scoring by MRI. We'll continue also about the very specific topic regarding the enthesitis, which is the enthesial blood flow and assessment, and also finally with the treatment of enthesitis with perspective of the imaging guided. I just reminding you today, if you have any queries, to insert your questions in the chat box for us to allow us to answer your queries, and reminding you also for tomorrow. Tomorrow have a long day, starting from 9:30 a.m. We'll start with an face-to-face virtual with Professor Mikkel, and workshop for MRI assessment and scoring of the enthesis. And please, if you are coming, don't forget to have your laptop with you. It's already mandatory to attend the session. And the second part of the tomorrow also, we have a workshop for ultrasound with the most commonly examined joints. We have 4 speakers. You are instructors, and already will follow after the prayer time with a workshop hands-on session on real volunteers and patients. So it's my pleasure first to introduce our eminent first speaker, Professor Dennis McGonigal. Professor Dennis is well known. Actually, we are proud to use us almost for the third year. He's a professor of investigative rheumatology, professor at Leeds. He's a honorary consultant of rheumatology at Leeds Teaching Hospital. He gets his initial degree from UCD in Ireland in 1990 and awarded a gold medal, first class honors, and undertakes the PhD from Leeds and continue as a consultant starting from 2000. His work covers a wide spectrum of rheumatological condition. Also, the most famous is spondyloarthropathy, seronegative arthritis, gout, pseudogout, lupus, vasculitis, polymyalgia rheumatica, osteoarthritis, and rheumatoid arthritis. He have almost over 360 published papers in peer-reviewed journals, and actually his participation in the field of rheumatology allow us to understand more in different aspects of the diseases. And he has now inspired Ellen for over 2 decades now. Without further delay, Professor Dennis, the mic is yours.
Thank you, Professor Abu-Ghaber. Can you hear me now?
Yes, yeah.
Thank you, Dr. Abu-Ghaber, for introducing me. And thanks for asking me to speak at this meeting again. Enthesitis is very close to my heart. In fact, my aortic root is an enthesis, as we described a few years back because of the link with ankylosing spondylitis. And I have some disclosures. My laboratory gets lots of funding. And I'm going to be talking about the enthesis in psoriatic arthritis and spondyloarthropathy. I'll talk about the enthesis on bone, the synovio-enthesial complex, and I will be focusing down on the immunology of the enthesis. And it's a difficult tissue to study, but I will be telling you about this in vitro model system we have developed. So I work in Leeds, but I'm coming to you from my home in Ireland, in Northwest Ireland today. When I went to Leeds to study rheumatoid arthritis with Professor Emery, I discovered that Professor Wright and Moll there had discovered this seronegative spondyloarthropathy concept that everyone's familiar with, including iritis or uveitis, and nobody knew how these diseases were linked other than this clinical Venn diagram of overlapping features and rheumatoid factor negativity. So when I was, reading around these diseases, I caught the isolated enthesitis, which you're all familiar with, such as Achilles enthesitis. And when you look at X-rays of the spine in angst-spawned or psoriatic or Crohn's or ulcerative colitis, you see new bone formation, and it's at the enthesis, but the word enthesis is not used. Medical students or junior doctors are confused by a big mouthful, syndesmophytosis. So lots of things to put us off the trail. And in 1996, I wondered, maybe there's lots of enthesitis we're not measuring. And we started this idea that maybe enthesitis is ubiquitous. There was one paper the year before showing capsular inflammation in psoriatic arthritis using conventional MRI, which you can see is anatomically very difficult to interpret. And we did this first paper, this is just my introduction, in 1998, where we saw hidden enthesitis and osteitis here at the arrows in the knee joint in psoriatic and angst-spawned, but not rheumatoid. And then we put this model out in the Lancet in 1998, saying that the extracapsular inflammation is due to cytokine release from the enthesis. So cytokines being released from the enthesis, going into the bone, into the joint cavity, and into the extracapsular tissues, giving you this phenotype. And of course, several years later, 2013, Jonathan Sherlock did show that there were cells at the mouse enthesis that could make cytokine transcript. This was in 2013. But the problem we had was this, is that the enthesis is more than an isolated insertion site, and it's this structure called the synovio-enthesial complex. So when you talk about the enthesis, you have to realize that the actual insertion of the Achilles is 2 to 3 millimeters thick, and all that you have is fibrocartilage. There is no immune system. There is no immunity. How do you study the immunity of a system that doesn't have an immune system? Not very easy. And the immunity often takes place in structures here like the adjacent synovium. So people with an enthesitis may manifest as a retrocalcaneal bursitis because this is all part of the enthesis organ, with the fibrocartilage not just at the insertion, but also lining the bone. So that's the first thing you have to get your head around for this summit, is if people keep focusing on the insertion point, then you are missing the fact that the enthesis is an organ to dissipate force over a wide area. Now, this is the enthesis proper, the avascular area, and this is a patient with acute enthesitis of 1 month's duration with psoriatic arthritis. And what you see is all of the inflammation is outside the fibrocartilage, because the fibrocartilage is avascular and it does not have an immune system. And there's also some bone edema because the bone is vascular. And this is the problem you face when you study the enthesitis. This is the annulus in the spine, and the red is blood in the bone, and all of that white is fibrocartilage of the annulus, and it is completely avascular. When you digest tissue like this, you get one cell and one cell type only, and that is a fibrochondrocyte. So this is important when you study disease. Now, many of the other target sites in spondyloarthropathy, including the aortic root, the iris, the skin surfaces, the nail anchorage, and the long apex, are actually very vascular tissues, and they have immune cells in these tissues. But the large entheses are so big and so strong that there is no vascularization at the insertion, just an avascular tissue to stop immune cells getting into sites of immune activation. And obviously, this is the vascular eye, the iris, and this is a type of involuntary enthesis. It's not under voluntary muscle control, but under smooth muscle control. So 20 years ago, we put all of this together to say, well, because the enthesis is avascular, then cytokines like TNF are being released from the stromal cells at the enthesis, and then this is leading to inflammation of the type I'm describing in seronegative disease. And of course, people argue that, oh, enthesitis is just one thing. And one of the important observations we made was we followed up in the 1956 paper from Leeds, where Wright showed a strong link between nail disease and psoriatic arthritis. And we showed that the extensor tendon in the finger is actually anchored directly to the nail. And of course, this is micro CT in patients with psoriasis from Germany, Erlangen, showing microscopic new bone at the enthesis. And people with microscopic new bone, enthesiophytes, do go on to develop psoriatic arthritis. This is from Simon and Annals last year. So you see, although you're having an enthesitis summit, you have to realize that it's not just Achilles enthesitis or plantar fasciitis. The whole disease pathophysiology is linked to enthesitis. And this is our data from Leeds. When you treat the psoriasis patients and look at the subclinical enthesitis on ultrasound, the subclinical enthesitis and inflammatory lesions go away. So it's a really important lesion, and dermatologists may be preventing arthritis. Now, this is the original mouse model of primary enthesitis. It's a TNF transgenic model, and this model expresses too much TNF, and the TNF is made at the stromal cells at the enthesis. And this TNF then activates metalloproteases, and it activates angiogenesis and immunity, and then the immune infiltration takes place, not at the anchorage point, but in the adjacent bursa and on the paratenon. You can see all of the immune cells on the surface of the tendon. So the immune cells gather initially where there is access to the tissue via the vasculature. And this is something that you need to take with you when you look at ultrasound. The abnormalities may not be at the anchorage point, they may be in the adjacent tissue. So this is vital to understand, and we put this out 20 years ago, Michael Benjamin and myself, in the Journal of Anatomy, that it's an enthesis organ. And I just want to emphasize the organ here. And this organ, or synovioenthesial complex, is involved in lubrication of the joint, the synovium removes debris that may come from the fibrocartilage that's damaged. And then when a pathology kicks off, the close juxtaposition of the synovium and the enthesis leads to synovitis. And this is exaggerated in disease. Now, we also pointed out that there are many other structures that are not enthesis, but where tendons wrap around bones at the MCP or in the tendons around the ligaments. You get this synovioenthesial pattern inflammation. This is Zabotti's work from Italy, showing at the MCP, the inflammatory reaction at the site of physical stress at the functional enthesis. And this is the same abnormality on MRI. You see edema at the site of high physical stress and fibrocartilage within the tendon. And there's numerous examples of this. So when you're having an enthesitis summit, you have to think that the functional enthesial structures are also relevant. And a good example of one of these functional enthesial structures are the accessory pulleys. And this is the normal accessory pulley, which is thin, but in patients with a history of dactylitis, the accessory pulley is much thicker. And this is work by Ilaria Tanazzi, who worked with us in Leeds, who's based in Verona in Italy. And when you talk about enthesis, also you have to recognize that the enthesis is anchored to the bone. And the anchorage points of the normal enthesis to the bone are riddled with microscopic fractures and cracks in health. And this is probably why patients with psoriatic arthritis get very diffuse osteitis. And this diffuse osteitis extending along the bones is probably the reason patients get this florid periostitis, which is part of the GRAPPA radiographic, the Casper classification radiographic criteria is periostitis, but I'm showing you how this is all linked to enthesitis and periostitis. Now, I'm going to focus on the immunology. So we know there's a lot of genetics incriminating the IL-23 and 17 and TNF and other pathways in psoriatic arthritis and spondyloarthropathy. And we know that there's many mouse models now that people look at the mice, and the earliest abnormality these mice have is enthesitis. They also get dactylitis and nail disease and synovitis. And many of these models are driven by fungal adjuvants, which drive IL-23 and IL-17. And I've already shown you the TNF-dependent pathways. And this was the original paper by Sherlock, showing that the mouse Achilles, unlike the human, is very small, and there isn't a thick cartilage, and he was able to get some lymphocytes from this tissue. And he was able to show that when IL-23 is overexpressed in the liver, this led to a primary enthesitis on day 6, and then this spread to the joint to give a synovitis. These mice also got enthesitis in the spine, but look where it is. Here's the annulus, relatively avascular. Here's a ligament on the surface. And here we have the immune cells are accumulating initially in this space that contains the blood vessels. This is really vital for the imaging understanding of disease. So initially, the disease cannot be at the insertion because the insertion is avascular. The disease has to start somewhere else. And this is the issue. Just to remind you, this is an annulus in the spine. The white is completely avascular, so the inflammation and immunity starts in the bone or on the periligamentous tissue, and then the invasion gradually moves in. So how did we address this fact that the human enthesis is not the same as the mouse? It's too big and there is no immune system. Well, we cheated. We started looking at interspinous ligaments, which are very small and have a tiny fibrocartilage. And then when we digested these structures, we split them up into bone and soft tissue, and we looked at the immunology of the small enthesis because there's no immune cells in the fibrocartilage at large enthesis. And we used this roadmap. We knew that the skin and gut have resident myeloid cells or dendritic cells, and that these in the skin and gut likely activate skin immunity and barrier function in the gut. So Charlie in my lab first went looking for myeloid cells or macrophages at the enthesis. We stained the tissue and they were there. We then split the enthesis into the bone and soft tissue and digested both. Panel B, we sort the cells. Panel C, the cells are alive in the lab and growing. Panel D, we stimulate these cells with lipopolysaccharide, and then we get induction of IL-23 cytokine and also TNF from these cells. This is a paper with Ellen Gravelides' lab in Boston. And what we've done here is we've shown that the normal enthesis anchorage and the vessels in the tendon or ligament at the enthesis often have marginating neutrophils in health. And when we stimulate these neutrophils with a fungal adjuvant, we get quite high levels of expression of IL-23. And this is coming from neutrophils. So there's two myeloid cells at the enthesis that can be innate cells that can be made to make IL-23, IL-1, TNF, and other cytokines. So the next population of cells I want to talk about that are known to be in the skin are innate lymphocytes, particularly gamma delta cells. These are also in the gut. And here they are in the mouse. Here's the mouse enthesis from Reinhardt from Germany. And these green dots are IL-23 receptor positive gamma delta T cells, which are a type of innate lymphocyte that make IL-17. So in our lab, we purified these cells from the normal enthesis in the spine. And there's two populations, delta 1 and delta 2 gamma delta T cells. These are the biggest populations. There's at least 5 others, but let's focus on the 2 big ones. And we found that the delta 1s were more abundant in the perienthesial bone in gray and enthesial soft tissue in white compared to peripheral blood, where the delta 2s were more abundant in the blood. We sorted these cells, there's about 2,000 per gram of tissue, and then we did gene card profiling, and I'm only showing you transcripts relevant to the IL-23/17 pathway. And what we found was that the delta 1 cells in the enthesis completely lacked the IL-23 receptor. Yet when we stimulated these cells in the lab, again with cytokines and other adjuvants, we are able to get them to make IL-17A completely independently of IL-23. And we could also demonstrate this in other ways. So the delta 1 cells here lack the IL-23 receptor. When you stimulate with IL-23, nothing happens. But when you stimulate these cells via their T cell receptor, they make IL-17A, F, and 22 cytokines. So why is this important? The reason we did this was because IL-23 blockers did not work in ankylosing spondylitis. So the immunology we are doing is trailing clinical trials by a couple of years. So this is the opposite to what should happen in science. The science comes first, then you target the enthesis. But because the enthesis is so difficult to work with, and that's been very lucky for me, we know more about the bottom of the sea and the dark side of the moon than we do about the human enthesis immunology, because it's so inaccessible. I've told you a bit about innate cells at the enthesis. Now, what about adaptive cells that are present in the skin and gut? They're called tissue-resident memory cells, CD4 and CD8. So Abdullah Watad in our lab last year published this in Annals. Here is immunofluorescence of the enthesis soft tissue. And we've scanned 100 slides for 72 hours in an automated confocal system. And then we got this one picture of this nest of CD3 positive lymphocytes. So when we digest the enthesial tissue and stimulate it, we get CD4 and CD8 T cells that can make TNF and IL-17A. So every one of us have these cells in health in the soft tissue immediately adjacent to the fibrocartilage and also in the bone. So this immune system is present in health and it can be activated. And these tissues in health, they make lots of transcripts for TGF-beta, which is regulatory. Red is very highly expressed. And they also have very high expression of JAK1 transcripts, for example. So the JAK-STAT pathway is very activated and ready to go. And of course, in vivo, what happens is these proteins are made and then they get phosphorylated quickly, so the immune system kicks off quickly. So lots of JAK-STAT pathway activation. And then just to highlight, when we talk about the JAK-STAT pathway, we don't think of it as being particularly effective in enthesitis historically, because neither TNF or IL-17 directly go through JAK-STAT pathways. And I just wanted to highlight that other cytokines, including IL-6, use the JAK-STAT pathway. And this is an animal model that we did with Dirk Elwood. This is Catherine de Wilde. We published it 4 years ago in Annals. And this mouse model got inflammation primarily in the synovio-enthesial complex of the Achilles tendon. Remember, that structure is rich in myeloid cells. And when you walk, the Kager's fat pad moves dynamically up and down, and the Kager's fat pad is lined by myeloid cells or macrophages, and it's part of the synovio-enthesial complex. Sorry, I went too fast there. Now, in this model, this model is independent of TNF, but dependent in IL-6. And we're trying to figure out a novel mechanism why JAK inhibitors might work. And this is the severe synovio-enthesial complex inflammation at the tip of the Kager's fat pad. This is all myeloid cells. And here, when the mice are treated with tofacitinib, completely blocks the enthesitis synovio-enthesial complex inflammation. So this is just to remind everyone that in this summit, you're having that, you have to think of the whole structure, the synovio-enthesial complex and immunological heterogeneity. And now we're moving on to study the enthesis in much greater detail. And there is one cytokine that uses the IL-23 cytokine, which drives IL-17. IL-23 uses the TYK2 JAK pathway, and it's also used by type 1 interferon. And we do have novel JAK inhibitors that are TYK2 specific, coming potentially to treat psoriatic arthritis in addition to the pan-JAK inhibitors. And this is preclinical work here by Dirk Elowit's group, and they use a TYK2 inhibitor, and it completely blocks the enthesitis. So here's the enthesitis in the animal model, and here is the, as you can see here, from the myeloid cell, it's completely up. So why does the enthesis have an immune system? Well, entheses are sites of wear and tear. This is a normal patient's enthesis from Sybil Aiden, and this is a 27-year-old who has some loss of the hypoechogenicity from the normal fibrocartilage. So normal young people get wear. And we showed many years ago with Michael Benjamin that the normal human enthesis, by histology, has myeloid and lymphoid infiltration at sites of damage in older people. Now I've just shown you the immune system and the different cell types, and all of the cytokines that we target happen to be inducible at the normal enthesis, which is a site of damage. And so we have this micro damage, which I showed you earlier at the normal enthesis. So when you scan enthesis with ultrasound, you'll occasionally see microscopic erosion and new bone formation. This is all part of the normal cyclical process. And in our lab, we're very interested to see why people get new bone at the enthesis. So although I study the enthesis, I did my PhD on mesenchymal stem cells, which are osteoprogenitors. And we purified these in 2002 in arthritis and rheumatism. Leanna Jones is the stem cell biologist I've been working with for 25 years. And we've published this paper, for example, showing that there's a massive age-related decline in mesenchymal stem cells. They're virtually absent in the elderly skeleton in people in their 80s and 90s who get osteoporosis and osteoarthritis. These are papers that are much more highly so this is data. So what I'm finishing up is explaining to you, we have an immune system at the enthesis. The normal enthesis makes new bone, which you see in ultrasound, at the Achilles and plantar fascia. And this is work from our lab, which we published this year, Toby Russell. And I'm going to show you how IL-17A actually increases stem cell osteogenesis. And there's many other papers from around the world showing that the IL-17 cytokine in particular increases osteogenesis. So all of these immune cells making cytokines like IL-17 seems to increase osteogenesis. So here's the enthesis from the spine. We split it up into soft tissue and bone. And we study these tissues. So the top here is the enthesial soft tissue, and these dots are stem cell colonies. And there's many more in the soft tissue than in the bone, where the colonies are less numerous. But what I want to draw your eyes to is when we put these stem cells into osteogenic media and we add IL-17A, this dramatically increases the osteogenesis. So not only is IL-17A a cytokine produced at the enthesis, but it's also a cytokine that can increase bone formation. And this is much higher than with TNF. And again, using different conditions, IL-17A significantly increases osteogenesis. And IL-22 is another cytokine downstream of IL-23. And a few years ago, with El Zayadi from Egypt, who's a gynecologist who is working in our lab, he showed that the osteogenesis and calcium made by stem cells in our in vitro assays can be dramatically increased by IL-22. So these are cytokines downstream of IL-23. And then finally, in the paper we've just published, we found that IL-17A actually suppresses adipogenesis of stem cells. And remember, in the spine, the sequence of events is inflammation, fatty deposition or adipogenesis, and then that's linked to accelerated new bone formation. So the IL-17 cytokine is doing something more than TNF in the spine. And I just wanted to highlight this. Immunologically, in mice, when you knock out the gamma delta T cells that make IL-17 and you drill a hole in the mouse, a fracture in the bone, then this is mineralization in red. It's very good. But if the mouse has IL-17 knocked out, fracture repair isn't very good. And you can see this here on the bottom panel. In the IL-17, in the wild type mice, there's many more osteoblasts. But when IL-17 is knocked out, you lose the osteoblasts. So to finish up, we believe the normal enthesis has an immune system, and many of the cytokines that are produced there in health are fine-tuning tissue repair. And when you give high-dose steroids, the enthesis may rupture or tear or avulse because you are blocking this normal repair response. I wanted to finish up on a few other new things that we've seen which will be relevant to you. And it's around this, what are called the TH concept of T cells, TH1, 2, and 3. So it turns out there's two types of TH1 and TH2 helper cells, which has been around since the 1980s. And for the treatment of eczema, a drug called dupilumab blocks IL-4 and IL-13. And lots of reports have now come out in the literature of enthesitis development when people are being treated with dupilumab. And this is interesting because the IL-4 and IL-13 are genetically linked to psoriatic arthritis. And when we look in the lab, we find that the healthy human spine makes some IL-4. And here we have it, IL-4 is being produced by the T cells. And when we stimulate these T cells with LPS, they make lots of IL-23. But when we add IL-4 or IL-13, we completely block the IL-23-17 activation. So we believe when you treat people with dupilumab for eczema, you should be seeing this now from your dermatologist. Patients are being referred along to you for ultrasound, and they have enthesitis and seronegative arthritis, and we're trying to figure out why this is. So to summarize, the enthesis points towards a unified anatomical concept. The normal enthesis has an immune system, but not in the fibrocartilage. You have to look adjacent to it. The immune system's involved in repair. And I've given you this data linking the skin, the gut, and the enthesis, but the same is true for the aortic root and the ciliary body. There's a unified concept here, and there's this unique anatomy in immunity, and it's a really fascinating area to be doing research in. So here in my lab, Charlie, Abdullah, Rich, and many others, and Liana, that have been doing all of this work. And these are our buildings and leads where we do this work. I'm sorry if I've been on a bit too long, but I do get excited when I'm talking about enthesitis, and I'm happy to take any questions. Thank you.
Thank you, Dennis, for the great presentation as usual. You're always excited when you're speaking about enthesitis, as you said, and we are always excited with you on your talks. Thank you. Actually, we are running out of time, so I need just to ask you about a small question regarding, that you mentioned interleukin 22 as a main effector, especially for the osteoblast pathway, and it's responsible for the bone proliferation at the enthesial ends. Is there any trial to treat this or blocking the cytokine in the management of psoriatic arthritis?
Great question. Not that I'm aware. There is an antibody called fezacizumab. It's easy to remember. It's like the fez from Morocco, fezacizumab, and it failed phase 2 studies in psoriasis. So as a result, it was a Pfizer molecule, and as far as I know, they've stopped developing it. But there certainly could be a role for the IL-22 pathway because like IL-17, it can simultaneously be pro-inflammatory and pro-repair. IL-17 is a big player in gut repair. IL-22 is a big player in gut repair. And in the skin, IL-17 drives inflammation, as does IL-22. So it's a great question, and it's not something that's been directly addressed at this point.
Okay. I think we get one question from the attendees regarding the local injection of steroids in enthesitis.
Yes. Yeah. So obviously we don't inject directly into the Achilles, and I think one of the reasons we don't do that is it's a site of high physical stress. It's got an immune system. It needs to repair itself, and you may contribute to tendon rupture by injecting into it. But if you inject along the paratendon or the bursa, that's okay, isn't it, when there's inflammation? Some entheses you can inject directly into, like the plantar fascia or lateral epicondyle, because people don't seem to care, because one of the therapies for refractory epicondylitis or plantar fasciitis would be fasciotomy, which is not something I send my patients for very often. So it obviously depends on the structure. But yes, I think that's what we're moving towards, is to try and highlight to people that, the enthesis does have an immune system, and it's not just there for companies to make profits with biological drugs or small molecules. It's there for function, and we knew nothing about this because we never could access the enthesis. And the biggest problem was the enthesis under the old definition has 4 regions, and the fibrocartilage is 2 to 3 millimeters thick with no immune cells whatsoever. So when I started out, I thought that enthesitis had to be cytokines coming from the fibroblasts, which then diffused out. But that's completely wrong. I'm glad to report.
Did you believe that enthesitis occurs in stages? So whereas different cytokines act in different stage, and this also could explain why the axial is not responding well for interleukin 23?
Well, to be honest, when we formulated the Lancet theory 25 years ago, we found papers in the literature that injection of TGF-beta, IL-1 or TNF into the mouse knee joint and nothing else triggered a spontaneous synovitis. So our position was that any cytokine that was dysregulated had the potential to trigger enthesitis. So that was what the original theory was based on.
Okay.
Yeah. Okay. So we didn't have any deeper understanding.
Okay. We are getting more questions, so let's go fast. We have a question from Bahavna Khan asking about the JAK-UPA efficacy in enthesitis. What is the rule?
Oh, well, yeah. So there's phase three trials with a secondary outcome data with upadacitinib showing that it's superior to placebo. As a secondary outcome, and it was also numerically higher than adalimumab in AbbVie's Select PSA trial, where they had a comparator arm with adalimumab. So there is this interesting observation that maybe JAK inhibition will give you some benefit for the pain in enthesitis above and beyond the inflammation analogous to rheumatoid. So it's a great question. More data needed.
Okay, last question because of time. About the osteogenic pathway can be triggered by pathway rather than interleukin 22?
Can what?
Was the osteogenic pathway in enthesitis can be triggered by mechanism not dependent on 22 cytokine?
I think it's new bone at the enthesis tends to occur at the site of tension on the surface in the Achilles. So local anatomy and local biomechanics and the bone and mesenchymal stem cells are incredibly stress responsive via these channels, including piezo channels, which you're all familiar with. There's winning the Nobel Prize last month. So there's many local factors, and then there's growth factors like TGF-beta, hormones, PTH, etc. And then the cytokines then come in on top of that, including IL-17 and 22. So there's what I call cytokine fine tuning. So it's a very complicated area.
Okay, Dennis, if you choose about interleukin 17 and TNF alpha, which one is more related to the enthesitis in your concept?
Yeah, well, if you take the whole story and the story that's maybe emerging from many labs, you would get the impression that the IL-17 blockers may be better at preventing new bone formation. The only way this will be addressed is when we see the results of the head-to-head study from Novartis, who are looking with CT and X-ray new bone formation in the spine after secukinumab head-to-head with adalimumab. So this is the great thing about all of this research is there's never been an experiment done ever in any laboratory that's predicted anything. The clinical trials are leading the understanding, and then people like us are coming back afterwards and trying to fit it into the enthesis. So it's a great question. It will be answered very soon if there's any superiority. We will see.
Yes, thank you, Dennis, and to be with us actually. And we're glad that we will talk always and enjoy Ireland. See you later.
Thank you very much. And hello, Peter.
Yes.
Sorry for going over. Thanks.
Yeah, thank you. We are very happy and glad that we have Professor Damianov with us. He's well known with his contribution in the field of rheumatology and ultrasonography. Professor Damianov completed undergraduate studies and master's studies in immunology, PhD rheumatology in the University of Belgrade School of Medicine. He's specialized in internal medicine rheumatology and the full professor for internal medicine and rheumatology with the University of Belgrade. He's well known with his contribution with EULAR and have different publication even with the Belgrade score of the enthesitis with ultrasound. Just to move forward because we're out of time. And thanks, Professor Damianov, for being with us, and the mic is yours.
Today, I will speak about the ultrasound-guided injections in the management of enthesitis. And let me just share the full screen. I hope everyone can see it. This is my disclosure. And I started my career as a young rheumatologist, and even for more than 10 years, without ultrasound. And whenever I was giving injections to my patients using the anatomical guided landmarks, whenever I entered a needle in the body of my patient, I was always asking myself, where is the needle actually? Because we know from several very well-designed studies that about half of the targets that are designated by the experienced rheumatologists or orthopedic surgeons could be missed if we do not use ultrasound. When we go just by anatomy-guided needle, and that's very well documented. Then, of course, we very well know that we are not able to recognize the depth of the pathology, exact location, shape, or volume. That is another problem. And the third, probably the most important problems are that we are not able to miss, sometimes not able to prevent damaging of tendons or cartilage or ligaments or even blood vessels or nerves. We do not watch all the time these tissues and all the time watch and guide our needle. And that is the reason why we need ultrasound to guiding our interventions. And there are two possible ways of seeing needle under the ultrasound. One is transverse scan of the needle, where we observe needle at hyperechoic round spot. And that spot has below some lines that we call a comet tail. And using the live image on your right-hand side of the screen, you will see how it looks like. When the needle appears on the screen on a transverse view in the tissue, you will see a white spot. If you move the needle in the tissue, you will see this comet tail sign, which are very clearly seen. And you know exactly where the needle is regarding the position in the tissue. However, there is one important thing you don't know, and that is where the tip of the needle is. That's one of the most important questions. And to answer that question, you have to follow needle longitudinally and to see exactly where the tip and the rest of the needle is. Now here in this tissue, we have one needle on a transverse cross-section here, and I will enter with another needle from here, but longitudinally, and you will see how we can nicely observe the needle all the way through. This is the needle, of course. See, I was able to touch this small target, which is another needle. I will play a little bit with this another needle in the tissue, as you can see. Of course, these lines here are just reverberation of the metallic object, in this case, the needle. And you can see how extremely precise you can be. Of course, this was not done in a patient. Absolutely not. This was done on a chicken breast tissue as a model to learn doctors who didn't do that before, to learn them how to guide their needles under the control of ultrasound. You can see that that guidance could be extremely precise. Now let's go immediately to some examples of the small targets which are related to the tenosynovitis or enthesitis of our patients. So here we have a female patient with psoriatic arthritis, and you can see here that we have a sausage digit. Sausage digit is one of the hallmark signs of this disease. And here is how it looked under the ultrasound. Here we can see the strong inflammation of the tendons, two flexor tendons, excess of liquid in the tendon sheath, and inflammation in soft tissue around. We all know that dactylitis is practically a combination of enthesitis, synovitis, tenosynovitis, and inflammation of soft tissue around. This is longitudinal view, of course, but we will see at the same time, same patient, same digit with a transverse view. And you can see here grayscale, synovial hypertrophy, a little bit of liquid inside the tendon, and a lot of Doppler signal, as you can see here, which shows us how inflamed is the tissue. Are we able to reach this small target, which is practically close to 1 millimeter, even a little bit less than that? Well, let's see. This is the patient who is prepared for the intervention. And our goal is to stop the inflammation, stop the enthesitis, tenosynovitis with the glucocorticoid injection. Now, on the left-hand side, you will see a film that is myself doing the injection. And you see how it looks like. I have a relatively big probe. I was not doing it under the hockey stick probe, but this was a little bit bigger, but matrix probe. I'm following all the procedure on the screen and trying to do it in the best way. Now, I aspirated, I injected. This is what's going on down here. And I finished the procedure. Now, let's look how it looked on the screen. So see the region of interest, the target. Now the needle is entering the target. This was a 26 gauge needle, so very tiny, very thin needle. And you saw that the target was not thicker, not much thicker than a needle. Now I'm injecting the drug after aspiration and taking the needle out, and the procedure is finished. So you can be extremely precise, extremely accurate when you are entering such a small targets, like, let's say 1 millimeter thick targets or even lower. Now let's see some examples, actually 2 examples of the enthesitis of the elbow. First example will be the lateral epicondylitis. Here is the lateral epicondyle and common extensor tendon. And you know that at the lateral part, this is the attachment of the tendons, and this below is a ligament, lateral radial collateral ligament. This is the border between the tendons and the ligament. And what we all know is that tendons here are quite long. See, the muscles are starting here. So we have a long tendons of these 4 muscles. And let's see the example of a very severe inflammation. Now, first I will show you the normal medial condyle. where we have common flexor tendon of the four muscles, and where we have ulnar collateral ligament, which is thicker than the radial. And what is also very well known is that the length of the tendons is quite short. So the muscles, which are very strong, as well as the tendon, are starting quite after just a short longitudinal axis of the tendon. And here is the enthesis. Now let's see some pathology. This is the medial epicondyle inflammation. So enthesitis and tendinitis at this level. And you can, after you prove such an impressive inflammation and turn off the Doppler, you can enter the region with a needle. Now I'm going between the ligament and the tendons, trying to approach as short as I can to the enthesis. This is about 2 to 3 millimeters from the enthesis. And now I'm injecting the drug and slowly removing the needle. And you can see how precise you can be. Deliberately, I went between the ligament and the tendons, not to damage the tendons too much. Now we have an example of extremely severe erosive enthesitis of the medial epicondyle. And we can see that I entered here between the ligament and the tendons, and I changed the position of the needle and entered directly into the enthesis with the half of the dose of the drug. So again, you can be extremely precise when you are doing these interventions. Now let's go to another target. This is plantar fascia. And this is a normal one where we can see how it looks normally. This is the enthesis. This is the thickness at the level of enthesis, and quite a nice bright white signal at the level of normal enthesis of the plantar fascia. Now let's see the example of a highly inflamed, edematous, hypoechoic enthesis of the plantar fascia with the calcification close to the enthesis, inside the enthesis itself and inside the fascia. And these are the borders. See how thicker is the fascia than normal, and hypoechoic at the level of the inflamed enthesis. This is the Doppler signal from the enthesis itself and from the fascia itself. And the calcification again that we saw this, here it is. So how the procedure went on. See here, so I'm following the needle with the probe transversally, and always usually from medial side, never from the upper part. I never enter the needle there because I can then damage the fat tissue here. So probably always I go medially, I aspirate it, I inject it, in this case the glucocorticoid, and I went with the needle out. Now let's see how it looked on the screen. So this is the same patient, same enthesis. This is that calcification that we saw in other images. I'm entering with a needle, touching the calcification with the tip of the needle, going 1 millimeter back, and injecting the drug and taking the needle out. So you can follow the procedure extremely precisely. And you can, of course, reach the target apart from giving anti-inflammatory injection, or instead of giving that injection, you can do the dry needling or some other procedures, whatever you like or you think is needed in that case. Now, let's briefly go to another example, and that is one of the most tricky injections, and that is regarding the Achilles tendon. Not because the target is small, because the Achilles tendon is one of the biggest tendon of our body, but because it's the most trickiest part for the treatment, because we can risk the additional damage of the tendon, which we would not like to achieve at all causes. So that is why usually, this is the enthesis you see with calcifications, with hypoechoic areas, this is the needle. I'm always entering the paratenon of the Achilles tendon. I usually almost never go to the tendon itself, though I will show you very nicely that this is the inflamed, of course, tendon, and there is some inflammation at the level of enthesis. See the Doppler signal and erosion. Now I'm entering the needle in the paratenon, the tissue, the fast tissue, the tissue which is surrounding the tendon. It's not, of course, synovial sheet, but it's a fibrous sheet, so fibrous tissue, and I almost never enter the tendon itself. See the needle? We will go a little bit back here just to see how it looked like. See here. So what I would like to do is to enter here. This here is paratenon, the fibrous sheet of an Achilles tendon, and then I'm sure, because I witnessed that many times, that the drug will go in the enthesis itself, and it will go around and be absorbed by the tendon. Now let's see, is it really so? Again, so see the needle is entering the paratenon. I'm injecting, and you can pay attention here. See how the drug is going down at the level of enthesis and filling this space without entering the needle directly in here. So that is how you spare the tendon and enthesis of being damaged by the needle. This is another example where we have the retrocalcanear bursa, and that's much more easier. So if you have the bursa filled with liquid, you can enter the needle without a problem. And of course, aspirate the liquid, which I'm doing right now, and then inject the whatever drug you consider appropriate. And then you don't have to be afraid of damaging either tendon or whatever tissue around if you follow the procedure in a proper way. However, let's go back to another example of the Achilles tendon, where we had at the same time, we had several problems. First, this is the right tendon of the same patient, and this is the left tendon of that patient. And this was a huge partial rupture, huge edema of the tendon, as you can see, and huge edema and hypoechogenicity of the enthesis, which was highly inflamed, along with the tendon itself. And it started after a minor injury, while patient was climbing stairs. So it started in January 2018, and this is how it looked like again on a closer view, where you can observe the enthesis better. See how tiny is enthesis on a normal, where the normal tendon is on her right foot, and this is the highly inflamed enthesis and the damaged tendon of the left foot. Now, the lady was treated not with glucocorticoids, because that would be a huge risk of additional rupture, and then she should be operated. Oh, sorry. And I started to treat her with a blood cell secretome, orthokine, which is a serum which is filled with a lot of growth factors, a lot of anti-inflammatory cytokines, and proteins that are stimulating the repair of the tissue. And this is, by the way, the transverse cross-section of the left Achilles tendon, highly inflamed, and of the right Achilles tendon of the same person, which was normal. And now let's see how it looked like briefly. This is transverse cross-section, and now what I have done. Again, I'm entering at the fibrous sheet, at the paratenon, and injecting the drug. And you can see the drug is going all around. This is the part, these are the parts of the air bubbles that are showing you, but see how the paratenon is extended here, and the drug goes below as well. So if you enter the paratenon, the drug will go all around. In this case, it's Cytokine, her own serum, where the blood cells were previously stimulated to produce a lot of good molecules, which will help the repair. And that was done, in her case, 3 times. At the beginning, this is the tendon in question. Then after 5 months, next injection, and 6 months, after 6 months, the third injection. Now you can see how the tendon looked like after 5 months of the first treatment. Then after the first treatment came the second injection here. And this is the third injection. Now let's also see the function. This is how thick the tendon was at the beginning and later. See, some fibrous tissue stayed, of course, here and here. However, the tendon was wonderfully repaired. See this structure and this here, there was a repairment of a lot of fibers, and the enthesis, which was quite thinner. There was also the recover of the enthesis. And while she, at the beginning, her was pain was 75 out of 100 when she walks on a flat surface, and 90 over 100 when she tries to climb stairs, which she was not practically able to do. After 5 months, it was just 5 over 100 pain during walking on a flat surface, and 20 over 100 with stairs, and without any pain after third injection, and just a little bit of discomfort associated with climbing stairs. So this was one very successful example of the treatment of the Achilles tendinitis, enthesitis, and tendinitis, including the partial rupture. However, you have to be very cautious when you treat Achilles tendon, and be very careful not to damage the tendon itself. Particularly very careful if you use glucocorticoids in this case. So that is why at the last third of my talk, I will show you briefly the list of the most commonly used drugs when we inject tendons or enthesis. And I will discuss a little bit one of our studies where we did the double-blind study comparing to the type of treatment and looking for the result when we treat enthesitis. So this is list mentioning, of course, glucocorticoids, hyaluronates, blood-rich plasma, autologous conditioned serum, or how we call it, blood clot secretome now, which is the better name for this Cytokine method. Then collagen, stem cells, radioactive isotopes, prolotherapy, combination of these therapies, and their list is much bigger than this. However, I would like to show you one example where we did a study where we decided to treat one of the most common pathology of the shoulder, and that is the chronic enthesitis and tendinitis of the supraspinatus tendon. And these are example of the erosions and Doppler signal from the enthesis of the damaged tendon. And we did a study where we had a prospective randomized double-blind trial, controlled trial, where we tried to test autologous conditioned serum or blood clot secretome, meaning Cytokine, injections, and we compare it with betamethasone and placebo injections in the treatment of chronic shoulder joint pain due to supraspinatus enthesopathy and tendinopathy. And what were the results? This is the patient that is prepared for the intervention, by the way. And here is the way that we were injecting. I was actually doing all the injections where I injected the blood cells secretome. There is a special filter that we use when we inject this, but this is a serum rich with good molecules. And as you can see up here, you can see the part of the screen, you can see the needle where it is entering the enthesis. But of course, I will show you, I will stop this film. I will not proceed all the procedure, because now when I'm in the enthesis, I'm aspirating, giving the half of the dose usually. And then I change the position of the needle and go into the paratenon. Go into the paratenon and then inject the other half of the dose. Now let's see how it looks under the screen. So this is the enthesis with some calcifications, and the needle is entering precisely into the region of enthesis. And now I'm injecting the half of the dose of orthokine. And then I have to end here, below the ligament, and of course, above the subacromial subdeltoid bursa. So I'm now in paratenon, not in bursa. If I would be in bursa, the drug will disappear in bursa and would not work on the tendon itself and enthesis. But if you inject in the paratenon like I did here, then you see two things. First, you can see that as you can see, the paratenon is expanding a little bit because the drug stays there in the loose connective tissue of a paratenon. And then you are sure that you injected in the paratenon, not in bursa. But with the ultrasound, you can very easily distinguish paratenon tendon sheet, fibrous sheet, from the bursa itself. It's not a problem. And then you inject the drug. Another example from this same study. So the first part of injection goes into the enthesis, and the other part goes into the paratenon. You should lift the ligament is lifted and the drug stays in paratenon, and you're sure about it. So what were the results of this double-blind study? Of course, I was giving the injection, and other doctors were measuring the effect who were blinded, which injection was given. And after 4 weeks, we had improvement in both therapies. So blue is betamethasone and red is orthokine. And as you can see, the both were similarly good. Orthokine a little bit better, but it was not a significant difference. However, after another 5 months, actually after 24 weeks, we had decrease in the effect in betamethasone group, and we had additional increase in the effect with the group of orthokine. So at the end of the 6 months or 24 weeks, we had actually highly significant difference in the VAS pain between the two groups. Now, what about the constant shoulder score, which we also measured, of course? So, where we had blood clot secretome group, we had a significant drop of the number of patients with a poor outcome, and it was very low after the 24 weeks. The excellent result was very low at the beginning in both groups, without any statistically significant difference. And it went even a little bit down after the first 4 weeks regarding the blood clot secretome. So we were not very happy at this part. Those who knew the results, because I didn't knew it until the end of the 6 months. However, after that, the outcome was not so good for the group with the betamethasone. See, the excellent result was increasing, but not so much. And the number of those who had excellent constant shoulder score after 6 months, and they were treated with orthokine, was really, really significant. So at the end of the treatment period, the 6 months follow-up, the difference between in the favor of orthokine in comparison to glucocorticoid and placebo, because we gave 3 glucocorticoid injections, the 4th was placebo to match the 4 injection of the orthokine. So that was really significant improvement in the orthokine group in comparison to glucocorticoid. So this is one example how you can design and conduct and of course published double-blind studies in treatment of enthesitis and tendinitis, and how you can compare drugs, because we do not have enough experience to tell which from this huge list of drugs is really far the best and which are not so good. So we are still waiting for more results, and everybody is welcome to do the studies. So what are the advantages of ultrasound-guided injections? First, they are very rapid, as rapid as anatomically guided. There is no major difference. They are extremely accurate and reliable. You have practically minimal, I would even say no risk of damaging cartilage, unwanted damage, tendons, ligaments, nerves, or blood vessels, because you can see them. So the risk is really very, very low. You continuously monitor the needle placement. You monitor the drug that is entering the target that you want to be entered. And it's extremely useful in the small and deep targets, where practically you cannot reach in vast majority of cases without seeing it under the ultrasound. And that's where I will stop my talk. And I would like to thank you very much for listening. And I would be honored if you have some questions.
Thank you very much, Professor. Very nice presentation. That's where the value of ultrasound is always added, of course. I have a number of questions, if you don't mind answering them.
Of course not.
So the first question says, if you injected an Achilles tendon and there was an incomplete response, how long would you wait before you proceed for the second follow-up injection?
That's a very good question from the clinical point of view, and it's not an easy answer for that. Why? Because sometimes we have a long healing process, and it depends partly from the image that you can see while you are controlling the patient. For example, I would now give just a very quick example of one of the basketball players I was treated with orthokine, who came to me with a problem, and he had to be very shortly in my clinic because he had to leave to United States where he plays basketball. So in this young person, I saw after the first injection, I saw the huge improvement. The edema was very low in comparison to because I gave it every day. So when he came tomorrow after the first injection, I was asking myself, did I made a mistake? Is it another leg? Because it looked very good. However, in some cases, this case that I showed, the lady with one systemic disease, that was very hard. So it was very slow. It was very slow. And you have to be very careful in observing clinically patient and observing under the ultrasound and measuring the quality of life, and then to decide, are you going to proceed with the treatment when the process of recovery is very slow, or you will change the way of treatment. So there is no definite answer.
Thank you very much, Professor. So how about PRP? Do you use PRP when injecting, for example, shoulders or Achilles tendons and so on?
I do. Personally, our group didn't do the studies with PRP, so that's why I didn't show any results here. There are results of other authors, and results with PRP are relatively good, or we can say quite good. there are some studies with very good results. There are, you can see the new recommendations for the treatment of osteoarthritis, where PRP is also very present. Some of the recommendations favor PRP, some not. So you have some very, very serious recommendations where they say, no, we highly do not recommend, we are highly against PRP, for example. However, so it's not really a very clear situation with PRP. There are some comparison studies of PRP and orthokine in favor of orthokine. However, PRP is still used many doctors are using it, orthopedic surgeons, rheumatologists. So we will have to wait for another studies to be really sure what is the real value of PRP.
Thank you very much. I have a few questions that maybe I combine them because of the time. What kind of corticosteroid do you use, and do you have a certain concentration that you use for each joint?
Yes, good question. Well, you know, despite the fact that triamcinolone hexacetonide, which I consider one of the best glucocorticoid drugs for the big joints and for the synovitis, despite the fact that they are also recommended for small joints or tendons, I would say that I do not use it in enthesitis because I'm afraid of the dehydration of the tissue, and that is why I don't use it. Simply, I don't. Maybe some one of you have the experience with triamcinolone hexacetonide and enthesitis, but I usually use betamethasone and triamcinolone acetonide, which are not so strong, so they do not dehydrate the tissue, and that's why you don't have the damage. So I have no experience with hexacetonide, so I cannot tell, is it good for the enthesitis? Because I'm afraid, I must say, I'm afraid of it. However, maybe someone had better experience with that. Otherwise, I use triamcinolone acetonide with one acetonide ending in the molecule, and not 6 ones, but 1. And of course, betamethasone. And experience is very good, and results are good. Short term, though. Short term, not so long.
Okay.
But sometimes short term is enough to recover the enthesis.
Have you used other drugs other than cortisone, like methotrexate or biologics?
No, I didn't. Neither my group, because there are recommendations highly against these drugs in the treatment. We have anecdotal attempts. Even we have some positive reports, but still we don't think these positive reports are good enough. In the recommendations, these drugs still are not recommended, and that's why we simply hesitate to use it in a treatment in our patients.
Thank you very much. So one final question from Iman Suleiman, which is, for plantar fascia injections, do you go inside the tendon or just above the fascia?
Well, when enthesitis is the question, and this was the talk about enthesitis, I always go into enthesis. In this case, I always go into enthesis because otherwise, because it's quite tough structure, I don't think that injection in the fibrous sheet would be good enough. So I was learned by my teachers that I should go into enthesis, and I started it as a very young doctor and continued it, and that has a good results. And I didn't face any damage, mechanical damage of the enthesis of the plantar fascia. So I'm satisfied with this approach, and the effect is really good.
Thank you very much, Professor Deminov. It's been a pleasure listening to you tonight, and we hope to see you soon.
Thank you very much for your invitation. It was a great pleasure. I wish you a great meeting and good health for all of you. Thank you very much.
You too and your family. Thank you very much.
Thank you. Bye-bye.
Thank you very much. We have an old friend of ours joining back after some technical difficulty. So it gives me really great pleasure. Long time no see, Professor. Really nice to see you. Professor Peter Brilliant, who will tonight talk about the role of ultrasound and scoring updates. Without further ado, we will be presenting the biography, and Professor Brilliant, always nice to see you. Thank you very much.
Thank you very much for inviting me for this meeting, and welcome and good afternoon to everybody. So that will be my topic, role of ultrasonography and scoring updates. That's my disclosure. And if you just think about what is the role of ultrasonography in detecting enthesitis and scoring and follow-up, of course, we have to go back what really means diagnosis. And diagnosis is a Greek word, and it means dia, through, across, via, or between, and gnosis is knowledge. So when the doctor examines on enthesis or any part of the body, of course, always have to look of the patient and need to touch the patient, and always have to think about the pathology, the anatomy behind this region. And if we can use sonography, we can learn and we can have more data than simply clinical examination. And today, ultrasonography is the only method to look under the skin thoroughly in real time during the physical examination. So that's the role of ultrasonography. At this time, we are able to use during the physical examination, just like another tool for ultrasonography. So that's the real role of sonography. And in this my talk, somehow I would like to show you a normal vision of enthesitis and enthesis and pathology. You know quite well, some people has a myopic vision when you can look, the close things quite sharp, but in the far part is not so sharp, or in the opposite, when you can see far quite clear, but not in the near field. So I will try somehow to show you the normal vision of this. What we are available in our hand as a imaging tool, of course, we have a B mode, and we can use on the B mode in a static image. I just show you in the Achilles tendon, and you can see here an erosion. So we can use B mode still, and we can see different normal and abnormal part of the enthesis. Of course, we can use a dynamic examination on B mode, and Professor McGonagall mentioned the Kager's fat pad, which is in the on the surface. You can find myeloid cells. We cannot see the myeloid cells, of course, in ultrasound, but we can use for a dynamic examination, and you can see how is the Kager's fat pad going between the Achilles tendon and the calcaneum bone. And after B mode, we can use power or color Doppler mode, and we can evaluate, we can assess on the image, a static image, where we can find blood flow, what is normal, what is abnormal blood flow on around different entheses. And of course, we can use video clips as well. So we can see the Doppler signals in video. We're not using any dynamic methods because it's a very motion sensitive, the power and color Doppler. But on static image, you can, of course, follow the blood flow, and you can use a video clip to be sure what is on the real flow. What is the first task for us? Of course, for detecting enthesitis on ultrasonography, the first task will be to learn the gross anatomy. So we have to know exactly where is the Achilles tendon, for example. The Achilles tendon runs distally, and you can see here at the superior pole of the calcaneal bone, there is a bursa called retrocalcaneal bursa. Some fibers will be attached, and that's the strict name of the enthesis, but some will run over the heel, and that will be the first task. We learn there is continuous fibrous on the larger segment of the tendon aponeurosis, or as a part of the tendon. Again, you can see here in the Achilles tendon, some fibers will attach to the calcaneal bone, and some will run over the heel and even continues in the plantar aponeurosis, or absolutely the same at the knee. You can see the quadriceps tendon, some is running over, some fibrils over the patella, and here is the attachment of the patellar tendon to the tibial tuberosity. So that's a larger segment, of course, of the enthesis and on the collagen fibers. The second task will be to learn the microscopic anatomy. And as Dennis mentioned, we have different type of fibrocartilage around our enthesis, many entheses, not all of them, but many of them. For example, again, here is the strict the enthesis. You can see there's the enthesial fibrocartilage. You can see over the calcaneus, there is a periosteal fibrocartilage, and just the inner surface of the Achilles tendon, there is a sesamoid fibrocartilage, and between them, there will be the retrocalcaneal bursa. Interestingly, when they examined the earliest sign of the differentiation of the enthesis organ beyond the enthesis establishment of itself was the development of the retrocalcaneal bursa. So the strict enthesis and the retrocalcaneal bursa is very close to each other even during the development of the human Achilles tendon enthesis organ. The third task, of course, will be learning somehow the anatomical and the pathological blood supply around the enthesis. And then I choose the premier enthesis, the Achilles enthesis, and you can see on this different anatomy or group, you can see quite nicely the small arteries and small vessels around the Achilles tendon. And we learn, of course, many other vessels around the small enthesis in the finger joint or in the hand. And you can see, for example, again in the heel, there is the avascular zone here in the Achilles tendon, and you can easily, you have to learn, not for the enthesis, but for the tendon itself, what is the critical zone, avascular zone, or watershed zone of the tendons, for example, in the Achilles, between 2 and 6 centimeters from the calcaneus. But the other tendons you have to learn again. You expect ruptures at this level of different tendons itself. Now we reach the resolution of Doppler when we can see normal small vessels around the enthesis. That's outside of the enthesis. You can see here in the top of the Achilles tendon, but absolutely in the same location than the anatomical microscopic histological slide as well. After, when you learn the anatomy, of course, you have to learn a lot of things about ultrasonography. You have to use your terminology, what we call echoic or anechoic, and I will use this term and hyperechoic and hypoechoic in ultrasonography. And of course, very important, the setting of the equipment. You can see underwater photographs, and just absolutely the similar in ultrasonography. That's the best settings of the photo. That's good settings of the photo. And the reason for this, because easily you can produce artifacts. Here you can see bad settings of scanning an Achilles tendon and the insertion. You can see it looks like a hypoechoic, looks like as a disease, but not if I change the settings, absolutely the same patient, you can see quite nicely the fibrils, and that's the good settings, avoiding anisotropy and any other artifacts as well. We need to somehow to standardize the examination of the enthesis, and we always try to somehow to use the different description of the anatomical distribution of the coronal, sagittal, and transverse plane. Of course, the probe position, you use the longitudinal or short axis view on transverse, the body and joint position, and we try to specify all anatomical landmarks using mainly anatomical sections or MRI examination. Just to show some example of the normal different entheses. Here is first the quadriceps tendon attachment to the superior pole of the patella. This region, you can see quite nicely the normal quadriceps tendon. Or in the normal infrapatellar enthesis, again, here is the patellar tendon, and you can see quite nicely this region. Or the normal tibial tuberosities, you can see even for the deep infrapatellar bursa, you can see it's a normal, again, the normal Achilles tendon. Even you can try to somehow to look your ultrasound equipment capability. You can see quite nicely the small amount of fluid in the retrocalcaneal bursa. That's the resolution, or the normal plantar fascia. You can see quite nicely here in this region. Then is already mentioned the fibrocartilage, which is simply a transitional zone, or maybe you can go tissue. Here is the tendon. Here you can see the tide marks, the calcified fibrocartilage, and the bone. So this region, and we know the fibrocartilage itself is not involved in the immunological process, but around in the tendon and the bone itself quite well known is involved in the process. We have no real data about the thing in the adult fibrocartilage, enthesial fibrocartilage. There are some published data on bovine example. For example, here you can see the fibrocartilage and some histological specimen as well. What is on ultrasound enthesitis? That will be the question. We know quite well what is clinical enthesitis as a rheumatologist. It means many times spontaneous pain at the enthesis of the patient. Sometimes you can see swellings around the enthesis, tenderness, and functional impairment. And we know quite well the pathological process, the focal enthesitis. Sometimes it's even including a larger part of the around the enthesis called tendinitis, bursitis, osteitis. So it's as an enthesitis organ unit. So what is on ultrasound on enthesitis? If we go back more than 60 years, this gentleman, the Austrian Carlo Dussig, described, and he used first ultrasonography in human to detect different lesions, but he described and used the articular tissues measurements, and he formed many postulates, which is very important still today. So, for example, hydration decreases dehydration, increases the attenuation constant, and he wrote a beautiful sentence on inflammation. Inflammation leading to edema formation decreases the values, but if cellular filtration occurs, values may be increased. So I really suggest to you to look this original paper. Even he's saying cirrhotic changes, which means fibrous tissue increase the attenuation constant. And still, if we think about what is the on enthesis and what is causing different changes in the enthesis, for example, hypoechogenicity, of course, the first is edema. And of course, there are some others, cell infiltration, increased blood flow, and others, xanthoma, and necrosis, of course. Or what causing looks like calcification at the enthesis, hydroxyapatite, or CPPD, or monosodium urate, or just post-injection corticosteroids, just mentioning what Nemanja said in injecting around or inside enthesis. And some is mimicking with acoustic shadows or without acoustic shadows. I just want to show you many things different behind what we are looking on. Looks like enthesophytes, for example, on ultrasound image and what is mimicking, for example, a joint level, maybe looks like an enthesophyte, but it's osteophytes in some case. What can cause thickened enthesis, many, not only edema or any other, but calcification, ossification, of course, is a plus material, so it's causing thickened enthesis as well. And what is the concept of the different pathology? And we wrote an editorial on enthesopathy, and in my meanings is enthesopathy is all different type of pathological process. So that's called, for example, degenerative, maybe mechanical lesion, metabolic disease, or inflammatory. And of course, between them, there will be some overlap, of course. Just think about in the normal life, somebody has, for example, psoriatic arthritis, 50 years old, but he was an athlete and he has a lot of mechanical lesions. Now he's overweight with hypercholesterolemia. So there will be many different factors what we need to count when we examine this patient. So first, in our group decided what we called enthesopathy and enthesitis. What is the possible ultrasound signs? And of course, we included the thickening of the enthesis, the loss of normal fibrillar structure, hypoechogenicity, erosions, of course, that's a very good sign for inflammation, cortical irregularity in psoriatic arthritis. Just think about that enthesophytes, which is quite common on mechanical reasons as well, intraenthesal calcification, and of course increased blood flow at the enthesis or a little bit far from the enthesis. And that means in the what we call enthesopathies, maybe a failure of the enthesis development, many different reasons, and of course many pathological ultrasound signs, of course. And in our group, the overall group decided, okay, we need somehow definitions for different ultrasound pathology, and we include enthesopathy at that time. And of course, we describe what we called abnormal enthesopathy. But later we have a lot of discussions. We need somehow to use not only enthesopathy, but defining somehow what we call enthesitis as an overall group. And here you can see we describe what we call hypoechogenicity and increased thickness of the tendon at the insertion. We give a new definitions for the Lena was involved in the first author and the Delphi exercise, what we call enthesophytes, what we call calcification, of course, what we call erosions as an overall definition, Doppler signal just next to the enthesis. And we include a new part, just to say it's less than 2 millimeters near to the bony cortex. We have to look the Doppler signals in abnormal case, and that will be somehow a definition for that as well. So we decided, okay, we need elementary component, B mode, and on Doppler as well. We decided what we called bone irregularity, calcification, enthesophytes, erosion, hypoechogenicity. Again, you can find in our papers these consensus-based ultrasound definitions as well. And on Doppler as well, Doppler signal at the enthesis, Doppler signal outside the enthesis, what we called bursitis. If it exists, we know quite well, not all enthesis has a next to a bursa. Some is without any bursa or not joint related or bursa related. Some is joint and bursa related enthesis as well. And finally, we agree on that we have to somehow to make two components, and it's accepted, inflammatory components and structural components. Of course, in the inflammatory, we included the Doppler, the hypoechogenicity, thickening, of course, and in the structural calcifical enthesophytes and erosions. Of course, there is overlap again, because if the patient has somehow erosions, and in the erosions there will be a Doppler signal, of course, that we call active erosion, and that's inflammatory and structural as well. If there will be only an erosions without any Doppler signals, of course, we can say that's a burnout erosion, and that will be just simply structural components. And again, we include the 2 millimeters rule for these definitions as well. So that was the final consensus, and we didn't include bursitis and independent lesions. Of course, many times it will go together with enthesitis and bursitis. The clinicians will call this enthesitis because they don't want to make any differentiation between, I think, bursitis, tendinitis, enthesitis, osteitis, when we're describing clinically lesions around, for example, in the Achilles tendon. Just some example of the abnormality. Here you can see an enthesitis of the quadriceps tendon, even some fluid and increased thickness of the quadriceps tendon. Here you can see the quadriceps tendon enthesitis and erosions, infrapatellar and enthesophytes, and again a thickened patellar tendon, a small amount of fluid in the deep infrapatellar bursa, again erosions in the Achilles tendon, and bony spur in the plantar aponeurosis. And later we learn, of course, there are many other entheses around our body. Our body is full with different type of entheses. So, and we learn, of course, the deep Koebner phenomenon, and the hand is involved many times, mainly in psoriatic arthritis, but in other spondyloarthritis as well. So just go back to show again in the 2 millimeters, so just next to the enthesis, when we can examine that will be somehow the role. What we learn as sonographers and the rheumatologists, of course, topography is very important. Here you can see power Doppler signals in the erosions, and next to the bursa itself, more in the bursa, and we need to somehow even normal, but in enlarged vessels around, and here it's feeding vessels in the enthesis, here around the calcification, some Doppler signal. And still a question is, how can we treat this patient? What is the best? Here, for example, the Doppler signals is mainly around the enthesophytes. So it may be an active enthesophyte, just growing calcification. So we need to treat the patient always in the same manner, or we need somehow, or what is really meanings, a different, let's say, stadium on the enthesitis, or just individual different process, or what this really means, and we're still working on that. I just want to show you some differential diagnosis, which is quite difficult. This patient looks like has an enthesitis just next to the inferior pole of the patella. You can see it's an enlarged, thickened patellar tendon, some edema as well, and hypoechogenicity. Here you can see the transverse image as well, but this patient has no spondyloarthropathy. He was just for a jumper's knee, and that's important to know the whole clinical case. You need to know when you examine, of course, in many times the history and the physical findings of the patient. And this patient was a very good Hungarian player, and he just was overused his knees. Where to look, that's very important. And we looked, for example, where do we expect enthesophytes, and we looked, that was at the Achilles tendon. It was mainly in the outer surface of the Achilles tendon, and very few in the inner surface. So always here you have to look the enthesophytes is just in the deep part, the outer surface. And we looked, of course, where is the erosions at the small enthesial part or more in the retrocalcaneal bursa part, and we find more in the retrocalcaneal part, in the synovial part of the bursa, and less in the enthesial part as well. And other group use quite similar approach, and they find quite similar results on where do you look enthesophytes and erosions itself. So that seems to be. We can find many times bursitis and tendinitis as well in psoriatic patient. We use very early, more than 20 years ago, Doppler and power Doppler, and you can see the second Achilles tendon and in two different planes there. And that's always important using sonography. You have to use two different planes to look the pathologies as well. And as earlier mentioned, other part of the bodies, including enthesis, of course, here is, for example, the lateral epicondylitis with Doppler. You can see the irregular bony surface and the increased flow as well. And as sonography improved in resolution and in techniques, we move smaller and smaller details, for example, the enthesial part of the MCPs and other joint or flexor tendons and on the pulleys to look and that region and to learn more on, for example, volar plate and A1 and other pulleys as well. So we looked dynamically as well. That's normal, but abnormal as well in trigger finger to look different small entheses. Here an example of a psoriatic patient with a normal nail and normal ultrasound image. You can see Doppler signals here under the nail, which is absolutely normal, and abnormal. You can see a thickened edema at the DIP, over the DIP joint in the extensor tendons, and the increased flow around the extensor tendons, which is pathological, of course. Sometimes you can see quite well something going on. For example, in this lady has a little bit swelling around the thumb when we looked, and when I ask them to remove the artificial nail, you can recognize very easily this patient has psoriasis, of course, in the nail. And when we looked on B mode, you can see the edema around the extensor tendon, thickened some fluid as well. And on turn on power Doppler, you can see quite impressive enthesitis and increased power Doppler signals around. So you can see quite nicely what is the difference between when you just look at a nail and when you can use a Doppler signals plus B mode on developing. If you look at the literature, some doubt, of course, on how can we use these new methods to say the 2 millimeters, and I just suggest to you to read this paper, Enthesitis in Psoriatic Arthritis, from the Italian group, Emilio Filippucci and Gianluca Smerelli was the first author to have doubt, of course, how can we use the 2 millimeters when we can see here many signals is far from the enthesis, and they using, for example, these two images, which is obviously a nice image. You can see more Doppler at far from the what we call the strict enthesis, or here the edema again, not at that part than the inflammation. And they have several examined. That's a picture of X-ray, and they try to measure and to use this. Here you can see around the pulley increased flow. That. So there is no full consensus of defining different elementary ultrasound signs and locations, which is great. We have a lot of debate on that, acute or chronic, what we call active and inactive, what is structural or inflammatory, what is exclusive specificity on any ultrasound sign in spondyloarthritis, or what we call enthesis, what is the broad and what is the restricted anatomical meanings. For example, how many centimeters from the tendon may be part of the enthesis, or just 2 millimeters. So that's an open question for many other people. Just discuss this. I just want to speak very little about the sacroiliac joint, because that's important in this patient group. Here you can see the sacroiliac joint, different amount around anatomical part. Here you can see in the medial view of the right sacroiliac joint, and you can see the auricular surface, and you can see the interosseous ligament, and you can see quite nicely here, for example, what is the enthesial part of the sacroiliac joint and what is the synovial part, and that's very close to each other, just like in many other joints, like for example in the knee joint itself. So we can put, of course, in the probe on the back of the patient just over the sacroiliac joint. Here you can see an example. You can depict on the surface, of course, just on the surface. Unfortunately, on ultrasound, we cannot see inside the bone, so it's all reflected, but that's the joint itself, and there is a normal vessels in this patient. You can see abnormal vessels in a spondyloarthritis patient. I'm still strongly believe MRI is much better to examine the sacroiliac joint than ultrasonography, but we tried it in the past. Just go to the scores, and I have to say the first published paper on sonography analysis of enthesopathy in lower limb was from Finland. They are Finnish people, not including at that time Juhani Koski, our friends, and it was published in 1994. And they looked for lower limb extremities on spondyloarthritis patient, and they tried to look for enthesopathy or enthesitis, and they examined 31 consecutive patients. And interestingly, that was the method. They found only on sonography, they found only 44 entheses with inflammatory lesions from 20 patients. And clinical examination, they diagnosed 56 sites on 20 patients, so more on clinically than on ultrasound. But don't forget that was more than 20 years ago, nearly 30 years ago. So that time, sonography, probably the resolution was not so good, but that was the first paper. And when I did my PhD, I looked at literature, and I was really strongly believe that's impossible, because the resolution is under millimeter with sonography, so it's impossible. The clinical examination is better than ultrasonography. And when we examine the larger part of group, obviously we find much more ultrasound positive at the lower limb than clinical positive. And we decided we need to somehow to create a score, and that's called the Glasgow ultrasound scoring system. Here you can see the different, what we examine, different lower limb entheses. We even try to measure exactly the thickness of this different, and the total score was 36. And I have to say, this ultrasound score, which was only B mode without any Doppler at that time, has a great career. And even when I look now on the web, even now some author using this scoring system just in November. They published this, and there was a conclusion of a Chinese group. A gas scoring system can be used to identify psoriatic arthritis in patients with psoriasis. I'm not agreeing with the total. I looked at total paper. There was many, not in my view, but still gas is a using score, and they still use it. Many others people and centers published several scores after this. I think more than 20 different scores published now. I just want to show you the Omerock group. George Brun was the first author to use a scoring system based on our data, and they include, of course, and we include hypoechogenesis, second enthesis, calcification, and bone erosion. And there was a grading for the Doppler based on our Lene, Terslev, and my paper as well, to call what we call punctiform Doppler signals and no confluent grade 1 and the others as well. That was only on Delphi exercise, and that was unpublished data as consensus. Obviously, we need to other multi-center studies to show that's useful. This grading system we need to examine, and independently from our group, many people have to check what is available and what is good, maybe in the future, to use this score. And for this reason, I have to say, be careful, because when you are using an ultrasound machine, obviously there is an engineering part and the physical process, so you need to be very careful to use the best machine for and the best settings to avoid any artifacts, of course. And the ultrasonographer as well, we need a well-skinned ultrasonographer to get the right results, of course, and we need somehow an independent writer, or the ultrasonographer will be very good for that, and statisticians to get the final. So there are many steps from ultrasound until when we finalize a paper, and be careful, because otherwise, if we're not using the proper methods, maybe the editor reviewers will rewrite on paper, and the reviewers and the readers will be shocking our results. So be careful what we really have to look in the literature, what is good and best. Thank you very much for your attention. I'm ready for your questions.
Thank you very much, Professor Valiant, for your valuable time. We have some questions from the audience here. For in calcific tendinopathy, so that's for the previous speaker. Could you please delineate the quadriceps tendon enthesis? Exactly on the image you showed, and where exactly to measure the thickness? Where do you measure the quadriceps tendon on ultrasound?
Yeah, when we use for a gas score, we use always at the edge of the bone or the maximum highest part of the tendon itself. So that was our measurement. And I always have to say, we always measure just a rectangle of the tendon. So I always try to somehow to put parallel with the skin surface and in the probe surface, and to measure, because that's easier for me if I'm using always a rectangle. I didn't use many times for different angle, because I think make more mistakes. But the anatomical landmarks always was the edge of the bone, or if it's impossible, we always use the largest diameter of the tendon next to the enthesis. Yeah.
Okay, so this is a specific question for a specific condition. A patient, a juvenile patient who's proven to have spondyloarthritis with sacroiliitis, who has patellar enthesitis. And on the other hand, there is another child with Osgood-Schlatter how to differentiate this from this on ultrasound?
Obviously, it's very difficult and very good question. If the patient has sacroiliac involvement and that's inflammatory, that will be clinically, so that will be no question. He or she maybe have some peripheral enthesitis as well. And always have to look for, I think in this case, for let's say subclinical enthesitis. So I will check in other region as well to look he has or she only a single joint. If it's a single joint, I have more doubt. You can argue, and that's true, some patient, juvenile patient has bilateral Osgood-Schlatter, so but it's unlikely he has or she in one knee and the other, for example, an Achilles tendon. You can look for different part of the, and that's depend on the age of the juvenile patient to look is already attached to the enthesis or not. So you can get, I didn't include any juvenile, but there is a good paper from somebody, when you can look at the different part of the enthesis during the age, and you can see the Osgood-Schlatter on different, the ossification center. So sometimes it's easy, sometimes it's impossible, of course, because maybe she's got two different type of pathology, Osgood-Schlatter plus spondyloarthritis. Yeah. Never forget we are not able to take any, for example, histology or any other. So you can argue on ultrasound, but for example, in Osgood-Schlatter, you can see sometimes Doppler signals, for example. If there is a pathology around the enthesis, is quite common, there will be some flow. Even in, let's say, diffuse idiopathic skeletal hyperostosis, that's not true, there is no flow. There is only in inflammation a flow. But if there is a pathology, there is always some small, due to the regeneration and different other things, the healing process, there will be some flow as well. Okay, so that's not differentiating.
Okay, so I have so many questions, but that one question in which I can combine in one. Is ultrasound diagnostic for sacroiliitis? And yeah, so the second part is, if sacroiliitis is part of the enthesitis to the interosseous insertion, is it a ligamentous inflammation or is it a joint involvement?
No. So the answer is, first, the problem with sonography is we cannot see the entire joint. So we can look we have the acoustic window. So that part, the resolution is very good, and the additive results we can see in increased flow or normal vessels in many cases. But unfortunately, this is the reason why it's not diagnostic ultrasonography for sacroiliitis, for example, because we cannot see the entire joint itself. The answer is, and if you look at MRI and other part, is sometimes there is obvious fluid collections in the synovial part of the joint. And that means synovitis in this patient group, in spondyloarthritis, just like on the knee joint, for example. Many times spondyloarthritis patient has a synovial inflammation and fluid. But many times on the MRI, you will see an enthesial part inflamed, and there will be, for example, bone edema as well around and increased pathology, yes.
Okay, so a personal question from me. And we are always in discussion with Grappa about the involvement of ultrasound, in the classification of patients, and also, in putting each patient in the domain that they belong. But Grappa is not taking ultrasound on as quickly as it should, because I don't know why, but they should. What do you think about the role of ultrasound as a diagnosis and management of psoriatic arthritis, and the role of the big societies that they are not pushing for this.
Yeah. I don't want to say, I'm in the GRAPPA member, but I don't want to say what is the official GRAPPA, of course, statement on this. I will say what Peter Barnes thinks about this. And my answer is we need to look ultrasonography not like another imaging method. I have to say that's part of physical examination. That was the reason why I put in the first slide, because it's very simple. When I make a history and physical examination, even including ultrasonography, the physical examination, finally, I have a split view of the patient, saying one half of Peter Barnes saying that's enthesitis. The other part of Peter Barnes saying not enthesitis because it depends on the ultrasound findings. Always Peter Barnes, as a rheumatologist, using sonography, will say, yes, that's my final verdict, say this patient has enthesitis or not. And that's simply, just like we have to use sonography, like a hammer or like a stethoscope, we don't need to use as a separate imaging method. And that's my answer. And unfortunately, until everybody will learn the technique, we will finally say that's finally will be included everywhere. I think there will be somehow a debate between people who are using sonography and who are not using sonography. Who are not using sonography, they don't really want to include sonography, I think, for different domains. So that's my answer. I'm not a split, so I have no schizophrenic brain to saying, yes, clinically is not, but on ultrasound is yes. My final verdict will be based on both. That's the reason I never try to diagnose, for example, spondyloarthritis only on ultrasound, because I know I need history, physical examination, everything to look, even lab data, and finally I will decide if this patient has spondyloarthritis, for example, or not, or psoriatic arthritis.
Thank you very much, Professor. Always a pleasure to have you. Hopefully soon we will have you face to face.
Yeah, hopefully, and take care and be healthy.
Very much.
Okay, take care, and thank you very much to invite me.
Thank you very much.
Thank you.
Good night. Good night.
Good night to you.
Now we're going to move to and switch gear to our next speaker. It gives me great pleasure to present our next speaker, who's going to talk about the role of MRI in early diagnosis and monitoring. I will give the floor to my friend and colleague, Professor Mikhail Ostigard, and we'll have the biography about Professor in a second. So without further ado, Professor, the floor is yours.
Thank you very much. First of all, for the introduction. I guess that you've not heard what I've been saying so far because I was in the speaker ready room apparently. But anyway, thank you very much for being invited, and thank you to Dr. Walid for introducing me. And what I said was that I would really have liked to be in Dubai in real life now, and it was and if it wasn't because your next speaker, Professor Enthesitis, will actually have a celebration tomorrow because he became a professor 1.5 years ago during COVID. Then it would have been possible, but now it's not. The other thing is more important than going to Dubai, even though it would have been nice. So I have to only be here on, you can say, in this virtual format, and I also hope very much to visit you at some stage in a not too distant future. So what I'm going to talk to you about is enthesitis and MRI in enthesitis. And the way I'll do it is that I'll put most focus on peripheral enthesitis, because I guess that's what is mainly meant with this. And it's also what has just been described by Professor Balint regarding ultrasound. But on the other hand, I also wanted to put a little bit of attention to the fact that many of the changes we see in the actual skeleton is also enthesitis, and I'll talk a little bit about that in the end. And tomorrow we'll actually have an MRI interactive session, where we will show full MRI screens and full MRI scans, and I'll have some questions, and hopefully it will be enjoyable tomorrow morning. Right, so just to start out, spondyloarthritis is divided in different ways, and how I divided the talk is into the axial part and the peripheral part, with again the most focus on the peripheral part and the enthesitis there. But it can also be divided in other ways, and as it's been described also, there are different criteria. There's both ACES criteria for axial and peripheral SPA, where actually MRI is part of those, and the Caspar criteria, where MRI is not part of it for psoriatic arthritis. But I'll start off with the peripheral part. So enthesitis is obviously inflammation at insertions of tendons, ligaments, and joint capsules, or fascia, and it's a very important part of both psoriatic arthritis and spondyloarthritis. And it's reported to be quite frequent, particularly in psoriatic arthritis, but also in actual spondyloarthritis. The problem with enthesitis, and when you do imaging, at least MRI, where you are generally restricted to only looking at one area at a time, where it's easier with ultrasound to investigate more areas. There you're competing with the joints and the actual joints, or the actual components, regarding which area to assess. But you can very well assess different entheses, not at least around the Achilles area, the heel area, but also many other areas, as I'll come back to later. Ultrasound is for the peripheral part. I'm not going to talk about ultrasound because there are a lot of people who are much more know a lot more about that. But just mentioning that in clinical practice, ultrasound, of course, is you could say, serious competitor or a supplement rather, because compared to what MRI can do, because both of them are very good, and it depends on what you have available and whether you have good MRI people or good ultrasound people. But ultrasound is a very easy and very good method for peripheral enthesitis, as no doubt about that. But still, I'll talk about what MRI can do. So, and if you look into what the individual imaging modalities can do, then X-ray is not really helpful. It doesn't visualize the inflammatory components of enthesitis. It can show a spur or something like that, but it's not incredibly helpful when you have the patient. Ultrasound is much different. It can visualize enthesitis in the peripheral, in the periphery very well. So that's definitely a good option, and MRI can also do that. Its disadvantage, as mentioned, is that you can't do it when you have your patient in your room. That's also said by Professor Balint. The advantage by MRI is that you can visualize all areas, not only those where you have the acoustic window, and you can look inside and see if there's inflammation inside the bone. So that's the advantage, you could say, from MRI. And you can do different regions, all regions in principle, particularly it's often done around ankles. It can be done on fingers, where there's also a lot of enthesis, but it should also be mentioned that doing MRI of that quality you see in the middle image is not something that a normal MRI could do. This is dedicated trials, dedicated work done in Leeds, and the quality we look at when we do MRIs of the fingers are generally much poorer than this, but it's still possible to see important things. And then the advantage is the spine, where MRI for sure is the method of choice for evaluating enthesitis. So starting out with peripheral enthesitis, the heel region and the Achilles tendon insertion is, you can say, the typical and you can say, traditional place to look for enthesitis, first of all because it's very common, and secondly because it's fairly easy to visualize, and you can see changes, and I come much more back to that, in the heel region, both in the bone where you here see bone marrow edema at the insertion, and also in the soft tissues, both in the tendon and around the tendon and in the bursa. And at the same time point, of course, you get some information on the joints as well. Now I'll just show you how an MRI looks. I'll scroll through images of a heel region. They are 3 millimeters thick slices through the heel region in a sagittal plane. And so far we're, you can say, outside the heel region, but here now we start seeing the calcaneus. And as you get further in, it gets obvious that there is a little bit of things going on here around the plantar fascia insertion, which is also seen here, and particularly around the Achilles tendon insertion, where there's both bursitis and there's increased signal inside the tendon, which is also a bit thickened. You see a little bit of bone marrow edema, even not much, down here at the insertion. So this is an example of inflammation at the Achilles tendon distal pardon insertion. And as we scroll through, we come out at the other side. And here there's also a bit of bone marrow edema at the plantar fascia insertion. Right. So, and then it's interesting, even though I don't know the exact significance of this, that enthesitis can look very different. Here you see the patient I showed you before with inflammation in the soft tissues, the tendon and the bursa and so forth, and not really any bone marrow edema, or very limited. And here you see the contrary, where you have a lot of bone marrow edema, but very, very limited inflammation in the soft tissues, which would, and they would of course look very different on ultrasound. You wouldn't see the bone marrow edema there, so it would be minimal changes you'd see around here. So that's interesting, and what that translates into clinically and treatment response wise, but it's possible to see it all by MRI. And if we go down to the fingers, the same image as I showed you before, then there are different components. There is the capsule here on the side, which you can see, which is much brighter than it should be in this high resolution MRI image. You can also see that there is, at the corners of the bone here, there is some bone marrow edema at the attachment of the capsule. And there's also bone marrow edema in the middle of the bone here, which is more the area that you see as a part of arthritis. If we then look into a toe joint, the other was a PIP joint in the hand, then you will see similar things. You can see changes here around the capsule. You can see bone marrow edema in certain areas, particularly here in the corners of the phalanges, and you can also see bone marrow edema more centrally. And here, synovitis. So you can both see bone marrow edema, which is related to the insertion of the capsules, and bone marrow edema, which is more related to the arthritic part. But again, in the real life MRI images, they do not look like this, unfortunately. Enthesitis is also considered important by Grabham. As you see here, it's one of the 6 domains which are involved, they describe as involved, and which has its own treatment algorithm, and that where you should treat according to the manifestations you have. So it is definitely recognized. Also, even though the assessments we do clinically in is not of the same, it's not done as routinely by rheumatologists. That's what something we know from registries, that they generally focus on the joints, where the enthesis, even though you can assess it, is often not done and registered in the registry. So there is an importance or an important job for us to make sure that our colleagues do register enthesitis. And even though clinical assessment is not fantastic, then it's still better than nothing. At least you will focus on which areas are giving pain and are swollen. Right. Well, then now we're talking about MRI. So how should we do MRI? Well, generally, in the ideal situation, you'd have two perpendicular planes, which, for instance, if you're looking here at the Achilles tendon, would be the sagittal, and then, as you see here, which is in reality an actual image. But often you only have the sagittal view, which is also helpful, but you can see changes nicely if you have it in two planes. Then you use, most importantly, a water-sensitive technique like a STIR-T2 fat-suppressed image to visualize the inflammation. You can also use post-contrast images, but I don't think that it's that important. Honestly, I think you can see enough by doing T2-weighted fat cell STIR images. And then if you look for structural changes also, for instance, spurs or erosions at the insertion, then T1-weighted images are important. It's not necessarily needed to assess if you only want to look if there's inflammation. Then you can actually do it with only having the STIR sequence or T2-weighted fat cell. Sorry. There was some years ago done a literature research by Ashish Mashu to look into what there actually was of systems for assessing MRI of enthesitis, and that was quite limited and very varying quality and not really validated in different studies. So therefore, he developed a system which I'll come back to later. Then there is another issue that I mentioned up front in the start of my talk, that when you do MRI in the conventional way, then you have the disadvantage that you can only assess one region at a time. You can, of course, move the patient in the scanner afterwards, and that is possible then to do two, but it's still very limited as compared to, for instance, ultrasound. But then whole body MRI, which is it's not as new as it has been, but a newer method where it's possible to do images of the entire body in one examination, around 45 minutes, something like this, and thereby get information on enthesis and also joints and actual parts within one examination. And that was shown originally, the first paper in spondyloarthritis around whole body MRI was done in Germany and published 10 years ago by Wechbach. And obviously the image quality was not fantastic, but you were able to see inflammation both in peripheral and actual joints. And it set the scene as, for instance, you see a trochanteric inflammation here in the enthesis around that. There's also been some studies looking into what happens during therapy. This is one of them done in Germany. And again, it wasn't particularly detailed or high quality outcomes, because it was just how many sites seems to be involved at baseline in a etanercept treated group and a sulfasalazine group, and then you counted the sites that were involved, and you saw that it was reduced more here from 26 to 11 over a year in the anti-TNF group, and it was unchanged in the sulfasalazine group. So this illustrates that you can see change. It also illustrates a need for having an assessment method which is not only counting sites, but also is able to register an improvement in the findings you see in, for instance, the Achilles tendon. There's been other studies. This is from the same group from Germany, where they made this quite nice plot where they see where is it they find the inflammation or the inflammation on MRI, and the blue numbers are baseline, and the next is the next follow-up, and the right is the last follow-up, and so it's baseline year 2 and year 3, and you can see that the numbers decrease during etanercept therapy. But it also gives a nice illustration of that it's not only the Achilles tendon that is affected, it's also, for instance, around the iliac crest, and also in the axial joints around the sternum. Yes, and that is, you could say, more or less a similar study we did, where it was looked into which areas, which entheses were more frequently involved, and also found that the trochanter region was very frequently involved, together with Achilles Achilles tendons and ischial tuberosities. What we also did here was to look into if which areas improved during therapy, and that can also be of interest because it turned out that some areas were more treatment resistant than other areas, which can of course be one reason that it is just more treatment resistant, even though it's part of SPA. Or it may also be that it's that some of the areas we're looking at had the enthesitis due to normal, you could say, exercise or strain-related causes, which may not respond to a biological therapy. Whole body MRI can be used in different ways. Here, everything was summed up in a study, in a placebo-controlled TNF study, anti-TNF study, and looked into what happened over time in those two patient groups overall, and we saw an improvement higher with TNF if we added everything up and looked at things after 6 weeks. But seeing it from an enthesitis perspective, this next slide, where you have the upper right corner, is more important. And here you saw the same thing, that there was actually a significant difference already at 6 weeks in an enthesis score, enthesitis MRI score, between a placebo and an actively treated group. After week 6, they were all treated with a TNF, and thereby it evened out a bit. Then regarding whole body MRI, we have in the OMRAC group, also in the OMRAC MRI group, worked with this just as it's been done in the ultrasound group. And here we looked at whole body MRI and developed and validated a scoring system for whole body MRI, which is I'll show you in a slide more. But before that, we did a literature search, and again found out that the amount of studies that were dealing with this was fairly limited, and tried to learn from those studies. The scoring sheet you see here, or the areas that are scored, not the scoring sheet, but it's done in an electronic CRF. But here you can see that there are many areas to assess. But as people doing ultrasound knows, that you can learn it and do it in a fairly quick way, but it requires some training. On top of the whole body MRI work, which looks at all the different areas, both knee, hips, and fingers and so forth, then there's also been work around more dedicated enthesitis assessment systems. Both this by Ashish Mashu around the heel, which is the one I'll focus most on, and then more recently published this year, work by Marie Wetterslev around a scoring system for or scoring system, and an atlas for knees and hips, and they are published this year in seminars of arthritis and rheumatism. But focusing on the heel enthesitis scoring system, which I still feel is the area where we have the best data, then in that paper it was defined which things you should look for, both inside the tendon, around the tendon, in the bone, and in bursa when there were bursa, when there is a bursa, as there is in the enthesial insertion, but at the Achilles tendon insertion. But I'll show you that with images here. So first of all, we made line drawings and example images in an atlas, both for the Achilles tendon and also for the plantar fascia. And the first thing we defined was the intratendon hyposignal, which is, again, on a stir sequence, high signal intensity, which is consistent with an increased water content. It could also be post-contrast images on T1, but we mainly use just the water-sensitive images. And you see here that we are assessing up to this area. So it's all this area which is marked here, that is assessed. And here you see that the normal tendon should be black, but this is bright and indicating that there is an increased amount of water inside the tendon as a function of inflammation. Another thing is the inflammation around the tendon, peritendon hypersignal, where you see increased signal on the sides of the tendon. In this case, there's also some bright signal inside the tendon. There's also bursitis, but this is the areas that you look for on the outside of the tendon. Then there is a bone marrow edema, where we were decided that the area we'd look into was and along this area where there was the insertion, and then up to 1 centimeter away from the insertion of the insertion, and look there for bright signal on a water sensitive technique. And finally, when there is a bursa, then also look at that, because it's related to what is happening around there, and then had an assessment of the bursa, which is again, of course, increased water or enhancement on a T1 weighted image. Exactly the same was done for the plantar fascia, but I won't show you the images right now. Tomorrow, where we have this workshop for those of you that are participating, we will have real cases with heel enthesitis, among other things, where there will both be in the Achilles tendon and also in the plantar fascia. But again, we did not only look at the inflammation, even though I think that's where it's most interesting, but we're also looking at thickening of the tendon, even though that's slightly difficult actually, because what does that mean that it's thickened? It can both be an inflammatory manifestation, but it can also be due to more chronic changes. So it's difficult to use as a part of the adding up in a scoring system. And then there is the traditional ones, the enthesiophytes with abnormal bone formation and bone erosion. And if you look at examples, then this is an example of a thickening. But again, I don't like this assessment particularly much, because we should also consider how the MRIs cuts the tendon, and it can both be inflammatory and you say degenerate chronic changes. And then the spur, which here is very obvious and would be as easy to see on an X-ray, but you can see it here. And then erosions at the insertion as well, which may also occur, and which can also be graded. Then we made a scoring system, which I won't go into now, for the different pathologies from 0 to 3, with non-mild, moderate, and severe inflammation at all different locations, and that's been published as an atlas. And then just briefly, we have inside the whole body MRI system also looks at hips and knees before, but we felt it would be good to do some more detailed work on whole body MRI images, focusing on each individual region. And that's what we've done now, for instance, around did line drawings here for soft tissue and bone marrow edema involvement. But it's not more detailed than this. It's only soft tissues and osteitis separately. And Marie Wetterslev has published this recently. And the same for the knee joint. There's also been doing validation of inter-reader and inter-reader agreement of both joints and both of soft tissues and bone in the enthesis. With quite good results, even though it was better in the heel region. And we are working on publishing an atlas also, so that can be used for people assessing MRIs for enthesitis in knees and hips. This is an example from this atlas, which is not finalized yet, regarding osteitis in the region of the greater trochanter, where it increases by step based on the volume involved. This system for the heel is obviously also important to see changes over time, and you can do this by entering scores into an online web page. But for instance, here where you see now I have to move my cursor from the meeting here, so I can't see what I'm showing. But down here at the bottom, you can see a line drawing where you can assess the different pathologies. Now this is a stir image, therefore you don't assess the structural changes, but you can see that there is, for instance, considered that you have a grade 2 bone marrow edema down here, a little bit of periaponeurotic hypersignal, no signaling and no hypersignal inside the aponeurosis. It should be mentioned, of course, here that you don't see the aponeurosis as well in this slide, so you have to scroll back and forth through the entire area in order to assess and score. And then you see that after some treatment here, there is it looks much better. It's easier to see here around the Achilles tendon insertion where there's bone marrow edema, no bone marrow edema there, and inflammation here and there. So then some words around actual enthesitis, where there's no doubt that MRI is the method of choice for assessing this, because it's not an area where you have access by ultrasound. We should consider both the sacroiliac joints and the spine. If we look at the sacroiliac joints, they are here, and you look at them from the side, then there will be an anterior cartilaginous compartment and a ligamentous compartment with all the strong ligaments. So, where are we assessing the enthesitis? When generally you could say we are looking for that in the ligamentous compartment, because that's all ligaments and entheses that are inflamed. But there are also things which you can see in the cartilaginous part of the joint, which you see here. That's the cartilaginous part of the sacroiliac joints. And there, first of all, you can see capsule inflammation, like here, a right signal crossing here at the top from the capsule of the sacroiliac joints. That's one thing. And secondly, it's also important to realize that even the cartilaginous part of the joint is not a normal synovial joint. It's actually only in a small part of the joint, the distal 1/3. This study of histology has reported where there is a synovium, and thereby where it's a traditional synovial joint. while it's rather just the cartilage attached to the ligaments directly. Thereby, it's more a symphysis than it's a joint. So you can consider whether the reason that the that the sacroiliitis, a very high part of the sacroiliitis is related to enthesitis also, or to symphysitis. I'll skip this. This is just illustration of the histology. But if you look into where you see most inflammation in the sacroiliac joints, is it in the anterior cartilaginous part, the green one here, or is it in the ligamentous part? And consider this something different than this, the enthesitis part. Then you'll see that if you look at this, I know it's not so easy, but this is bone marrow edema, where it's seen both in the cartilaginous and the ligamentous part. And that is quite frequent in both non-radiographic XPA and AS, ankylosing spondylitis, as you see. That is a very frequent manifestation. But they would obviously be captured even if you only looked at the cartilaginous part. While those patients where there was nothing in the cartilage, that's a cart minus here, but something in the ligamentous part, that was incredibly few. None here, and only very, very minimal portion of the AS patients in cohort 2, cohort B here. So in reality, you'll capture all the patients that do have inflammation in the sacroiliac joint by just looking at the cartilaginous portion. So it's not so important in reality to look at the ligamentous parts. So there were no incremental value, as Ulrich Weber, you could say, wrote in his conclusion. What about the spine? And in the spine, there are a lot of different entheses. If you look at this line drawing here, then there is the anterior. Just a moment. Sorry about that. But the thing is that there is ligaments lying at the anterior and the posterior part of the vertebral bodies, the anterior and posterior longitudinal ligaments, and they attach to the corners here. And that's why we often see, very, very often see this inflammation in the corners of the vertebral bodies. That is in reality enthesitis related to these ligaments. On top of that, there's a lot of other ligaments. For instance, all those that attach to the spinous process, and they can be inflamed. You see inflammation in the spinous process and in the soft tissues between the spinous processes. There's also the transverse processes, which also have enthesis and ligaments attaching and muscles. So really much of what you see in the actual component is in reality enthesitis. Yeah, I just shown that, so I don't have to go through this again. Right, so if we look at the different manifestations of inflammation in the spine, then there is a discovertible one that's not enthesitis, the corners that is enthesitis. Then there is the ribs and transverse processes where there's a lot of ligaments attaching. That is mostly enthesitis. There's also a joint between the rib and the transverse process, but most of it is enthesitis. The facet joint is not enthesitis, that's a synovial joint. The costovertebral joint you can discuss because it's not a synovial joint, but it is a joint. And then there is the area around the spinous processes as well, and the soft tissues, and that's also enthesitis. So many of these, what we look at in MRIs in actual in the spine is really enthesitis. And this is just illustrating, and I'll show you this slide tomorrow as well, where we look into which areas you should look for. For instance, this is a costovertebral joint. What you have here is a transverse process and rib. But I'll return to that tomorrow. This is how the spine looks. And I won't go into detail with this now either, but just illustrating that you can see, for instance, the spinous processes very well, and they are sometimes bright. The same is true for the transverse processes and for the anterior corners and the posterior corners. And I'll scroll through that now, but just show you a few examples, which comes here right after. In the transverse processes, where a bright signal, as you see here in this region here, compared to this normal transverse process, and this normal transverse process, then this is bright, indicating that there is inflammation, and also here and here. So it's definitely possible to see enthesitis in this area on MRI. The spinous processes can be inflamed. That's purely enthesitis. You see it here, half of it, and in the next slide you see the other half. Bright signal in the spine, in the spinous process, an example of enthesitis. Obviously, you can also monitor this. It's important that you do it in a systematic way. But for instance, this goes in the, you can say, the other way than what you usually see. This is a baseline image where you see there's no inflammation in the transverse processes, and this is later where you see that there is inflammation. So it can of course change in both directions, but it's fairly easy to recognize that these areas are brighter compared to the neighboring ones, while these are all in the same color. This is another example of the traditional corner lesions, which are typical of axial SPA at baseline, and then only very limited inflammation left at follow-up. So with that, I'd like to end my talk by saying that enthesitis is, of course, a very important manifestation of spondyloarthritis, and that it can happen both in the periphery and in the axial component. And MRI is able to visualize them in both regions. For the axial component, there's no doubt that MRI is the method of choice. For the peripheral component, ultrasound is very, very helpful, and it depends on the ability of, you could say, locally on what people can do. The MRI is both a sensitive modality for detecting enthesitis, and it's also a sensitive method for monitoring enthesitis, seeing changes over time, both in the periphery and the actual parts. So that, I would like to thank you for your attention, and will stop sharing my screen. I'm happy to answer any questions.
Thank you, Professor Mikkel. Great talk as usual.
Thank you very much.
Thanks for being with us. We'll start reply to our questions here in the chat box. Please, for the attendees, if you have any queries or questions, please share it with us in the chat box. So we have a question regarding the non-radiographic axial spondyloarthropathy. Is it possible to have the normal MRI with a non-axial spot?
If it's possible to have a normal MRI in non-radiographic axial SPA?
Yes, this is a question.
Yes, that is possible. If you say, according to the classification criteria, you could say that there is two ways to get, I know that's not the same as a diagnosis, but there you can add HLA-B27 and have two features positive, and then you should have a negative X-ray to be non-radiographic. So in that way, it definitely is possible. But I think that you can of course have the you can have information peripherally, but I think that in reality, when you diagnose inflammation in the in clinical practice in the actual joints, then it is with MRI. So I think it's possible by convention, the way that we have defined it, but in reality, I think that you use MRI to document that you have inflammation actually.
Okay, so one more question regarding the chest wall enthesitis.
Yes.
Is the MRI sensitive enough to detect this type of enthesitis in patient with spondylar arthropathy?
MRI, I think, is very good for visualizing this inflammation. If you do an MRI for this purpose, then you can get beautiful images of both the manubriosternal joints and the insertions of, or the attachments of the ribs and this. So I think it is, you could say, you can definitely see it. There's not incredibly much work done around it, so it may be that something is missed now and then, but it is quite easy actually when images are obtained in a reasonable way.
Is there a specific MRI sequence so dedicated for
this type? But that would be in reality just the usual ones. That would be if you were really looking for that and wanted to do optimal images, then you would take T1 and a water sensitive technique, and then perhaps use contrast for a T1 weighted post-contrast image. The way you often see it, that's when you do MRI of the spine, and then it comes out as on the sagittal images, and you can then see the sternum here, manubriosternal joint in principle, but the best way of doing it is by coronal slices, where you both can see the sternoclavicular joints and the manubriosternum and the attachment of the ribs. So that's the usual, that's the best projection if you do it for that purpose alone. And then you can see it indirectly from the usual sagittal images of the spine.
Okay. About the fibrocartilage at enthesis, Michael. So it is about fibrocartilage.
Mm-hmm.
The visualization of the fibrocartilage with MRI. This is already an easy technique to have it, or it's difficult to apply?
Well, you see it, but assessing it is difficult. You could say you can see the cartilage, and you can do specific sequences which are good for looking at cartilage, as it's been done a lot, for instance, in knee or hip osteoarthritis. So you can do that. But honestly, what is normally done in actual SPA is to obtain those images that I described, the T1 and the STIR images, and that is not there. The cartilage is not very well visualized, but you can do it, but it's just normally not done.
Okay, but it is valuable to look for the fibrocartilage changes in enthesitis.
Please say that again.
Is it valuable to look for the fibrocartilage in enthesis to assess it early, or it's not? As far as we know that already, this is a primary site of pathology in enthesitis.
Yeah, no, but it's actually a very interesting question. I think a very interesting question. I haven't worked with it. We haven't done specific sequences to visualize the cartilage, but you gave me a good idea. But it would be relevant to see whether you got, in which extent you got additional information. But I'm not aware of people really having done it. You could say in a systematic fashion. So I'm not 100% sure how much you would see compared to and how it would be related to the disease progress, how easy it would be to see changes over time, for instance. I haven't tried, but it's an interesting question. I'm sorry I can't answer it better.
Okay. So we move forward we have also a nice question coming about it is easy to discriminate between osteophytes and the early syndesmophyte by MRI.
It's not the best method for it. There's no doubt that. So the answer is no. It's not the. You can see syndesmophytes by MRI when they reach a certain size, and you can see it at all locations. The thing with the location is an advantage compared to X-ray, but in reality, MRI is not particularly good for visualizing cortical bone, and thereby CT is for sure the by far best method for this. And if that's the only thing you look for, then CT would be the method of choice. X-rays are pretty good in those areas that it can visualize, but that's unfortunately more or less only the anterior part of the lumbar spine and the cervical spine. But no, it's not MRI strength. There should be more work on trying to improve it. For instance, trying to do synthetic MRI, synthetic CT, which can be done nowadays, and there's new methods trying to do that. But the sequences we use in general is not very good for that.
Okay. Another question regarding the mechanical versus inflammatory enthesitis on MRI. What is the differentiating features?
Well, first of all, it's not always easy, so it's also to differentiate. The thing that you see in which are, if we take, for instance, the Achilles tendon area, then the more inflammation you have, the more severe inflammation, that means more bone marrow edema, for instance, then it becomes, you can say, more and more obvious that it's inflammatory, both in the bone and in the area just at the insertion. Things like thickening of the tendon, I think, is a very frequent thing seen in the mechanical enthesitis, but it can also be seen in SPA. So it's not so that we can say pathognomically that this can only be this and this can only be that. In many cases, sometimes you're sure because there's no inflammation and only the structural changes, and other times, but very often you can't say it for certain.
Okay, we have one more question. What about the why is ligamentous part of sacroiliac joints is less positive than cartilaginous part in non-radiographic axial spine?
That's actually a good question, which I cannot answer. Apparently, it just is like that. All studies, it's also my personal experience, and it's also what the different studies there are more or less systematically done, shows that the amount of inflammation in the cartilaginous part and the is much higher, and it's seen generally earlier in the disease. And why it is so, I can't tell, but it is so.
Okay, so one last question because we are already out of time. What do you think, Mikkel, about the pattern of axial spondyloarthropathy and the psoriatic spondylitis? Is there a differentiating features regarding the MRI? We can take it from you.
I also think that's a very interesting question, which there is not enough knowledge about. We know that we know something. We know that there is more. Some of the posterolateral aspects, like inflammation in facet joints and in the enthesis in the posterior part, is relatively more frequent in psoriatic involvement than it is in the traditional, you could say, axial spondyloarthritis. But there is a massive overlap. It's decided, it's discussed a lot within the MRI field, how it should be defined, if definitions should be different, because it's also, another thing is that when in actual SPA, there is approximately 95% of patients who get actual involvement starts in the sacroiliac joints. And that is not the same in PSA. The sacroiliac joint is still more frequent than the spine, but it's much more even. We don't know the exact numbers, but it is more frequent to start off with the spine. So if you do have a psoriatic arthritis patient who gets pain, then I would not only do the sacroiliac joints, but also do the spine, because you may see changes there without having them in the sacroiliac joints. Yeah, and then there is the things we know from X-rays also, that endesmified shape is sometimes different in PSA, with being more bulgy than these slim vertical endesmifieds. But that's not the most early sign.
Okay, thank you, Mikkel. So we have to move forward, and so we can go more questions. We'll see how we can send it through email to Mikkel. We're happy to reply. So thank you, Mikkel, again. So see you tomorrow.
See you. Bye-bye.
Okay, bye. So now we have to move forward in our program, but firstly, we have to thank all our board member, Dr. Bahavna Khan, Dr. Rita Harifi, for heavily working actually in this program to have all this rich scientific knowledge regarding enthesis and enthesial imaging. So now we are going to our last speaker, Professor Lenny Treslev. Professor Treslev is well known actually in the field of rheumatology imaging and ultrasound, and especially in the subject of Doppler. And actually, this is her presentation today regarding the enthesial blood flow and its value. Professor Treslev is a consultant rheumatology and the head of rheumatology ultrasound division in Denmark. Already, Professor Treslev get her MD from the University of Copenhagen, Denmark, and her PhD actually was about the Doppler signal and Doppler ultrasound quantifications and detection and inflammation in rheumatoid arthritis. She has over 170 peer-reviewed publications and is well known in participation of ultrasound teaching and courses. And she received actually honorary membership from the EULAR and Queen Ingrid's Researcher Prize. Without further delay, Professor Treslev, nice to have you with us. The mic is yours.
Thank you very much, Professor Apohumal. Thank you very much for the invitation to speak at the third summit on enthesial changes. I'm very happy about being invited. As mentioned, my talk is about enthesial blood flow, the value significance, and its assessment from basics to scoring. And there will be some overlap with especially the talk from Peter Bayland. I also understand that we have some delay, and I will try to speed up the talk so that you can be not so late for your symposium. So I just need to be able to change. These are my disclosures. So as was already mentioned in the talk by Peter Bayland and also by Mikkel Østergaard, is that the enthesis is the insertion of the bone, but also a fascia, ligament, or joint capsule onto the bone, which is normally slightly elevated. And with the enthesial organ complex theory, it's not only the insertion that is of interest, but it's also the neighboring structures that helps to dissipate stress away from the attachment side. So when the enthesis inserts onto the bone, it actually sends in anchors into the bony cortex like roots on a tree. And it also then is suggested to involve the fibrocartilage on the lower side of a tendon, the fibrocartilage on the upper side of the bone, the bursa as an expression of a synovial lining, and also the calcified fibrocartilage. This is a picture, a histological picture from Professor Mike Benjamin, illustrating basically the same things, that in the Achilles tendon, which is always the example we use, we have here the insertion of the enthesis. Here we have the periostal fibrocartilage covering the tuberosity. We have here sesamoid fibrocartilage on the lower side of the tendon. This is the body of the tendon. This is the retrocalcaneal bursa and the fat pad. So the enthesis is only in this area of the Achilles insertion. So again, if looking at ultrasound, everything on the right red marker is the enthesis, whereas the whereas here we have the bursa, lower side of the tendon. This is fibrocartilage on the bone. Here we have the bursa and the fat pad. So looking into the enthesial organ complex also leads to having two different types of enthesial organ complexes. We have the extra-articular one, which is the one that was exemplified by the Achilles insertion with the enthesis, the bursa being the synovial lining, fat pad, and the fibrocartilage on both sides, under the tendon and on the bone. But we also have the opportunity to have an articular enthesial organ complex, where we again have the enthesis, sesamoid fibrocartilage on the tendon or the ligament that are involved. We have the articular fibrocartilage on the bones in the joint, and then we have the synovial membrane, which is not the bursa, but the joint cavity. And this is an example of how such a articular enthesial complex would look like. This is exemplified by a PIP joint, where we have the proximal phalanx, the intermediate phalanx. We have the articular cartilage here. This is a collateral ligament. And on the inner side of that collateral ligament, we have the sesamoid fibrocartilage, and we have the joint cavity. And what we can see with ultrasound is the collateral ligaments also in these small joints. So the probe orientation is marked with the red below, and this is part of the articular enthesial organ complex when looking at such a small joint. So what do we know about the normal enthesis? Well, there is this old study from 2005 that looked into the blood supply of the enthesis and found that there is no blood supply in the actual enthesis. There is in the neighboring structures, but not in the enthesis. And again, if we look at this histological picture from Professor Mike Benjamin, we see all these red vessels into the histological images, and seeing that in the end of the tendon, they're in the bone and they are just outside the attachment. And this has led to two different types of descriptions of enthesial involvement: the enthesopathy, which is the involvement, whatever the reason. So it can be a metabolic, inflammatory, traumatic, or degenerative. It basically just says that you have a pathological enthesis. But we try to reserve enthesitis as the inflammatory enthesopathy in spondyloarthritis. The reason there is a lot of focus on this is because it's a key feature in spondyloarthropathy, and that it is more frequent in patients with spondyloarthritis than in RA patients and in healthy subjects. If we look at the different types of enthesitis or in enthesis involvement, we have the one that we just talked about, which is enthesitis related to arthritis. And in this case, the perception is that enthesitis is the primary lesion. And with long-standing disease, it may spread to involve the body of the tendon or the bursa. If looking at enthesial involvement in sports, the conditions here, like lateral epicondylitis and jumper's knee, are believed to be a tendon lesion. And if the disease is long-standing or very active, it may spread from the body of the tendon into the enthesis, so that the inflammatory changes in an enthesis is more like an endpoint rather than the starting point of the disease. Finally, there are trauma to the enthesis, which is normally direct trauma to the enthesis, and may not involve Doppler activity. So ultrasound definitions of an inflammatory enthesis involvement, so enthesitis, is hypoechogenic and or thickened insertion of the enthesis that may exhibit Doppler signal if active. There may be erosions and there may be enthesophytes and calcification. But what is the very important one is that the especially Doppler activity must be within 2 millimeters from the bony cortex. So the first definition by ultrasound of an enthesitis came in 2005 and was recently updated in 2019. And these are the definitions that I just mentioned. The definitions were validated using the overacting validation process with the 4 steps, where the first step is to check the literature for already existing validity of the elementary lesions in an enthesitis condition. If these are not present, then there is a Delphi process where we define and agree on how the elementary lesions should be defined, and then they are tested in static images in patients. Then a scoring system is developed, going through the same steps 2, 3, to agree on the scoring system and test the validity in static images and patient. And once that is done, it can be used in longitudinal studies for sensitivity to change. So this was also done for the enthesitis. So we first had a literature review, then a Delphi and assessing the validity in static images and so. And the final definition are these. So we have hypoechogenicity and increased thickness of the tendon insertion. We have the enthesitis, calcifications, the bone erosions, and again, Doppler signal at the enthesis related to the close proximity of the cortex within 2 millimeters. And I will not read aloud the full definition, but they can be found in the publications. So what is perceived to be inflammatory changes are the presence of Doppler activity in the enthesis. But in case of not having a sensitive Doppler, you can use the presence of hypoechogenicity and increased thickness, whereas structural changes are the changes like erosions, calcifications, and enthesitis, and they are listed with a slash in between because the in the validation of these two components, they were found very difficult to separate in both in static images and in patients, and therefore they tend to be scored as 1. What was also decided was that bursitis was not an independent lesion of enthesitis, so it doesn't mean it cannot be involved when you have enthesitis, but only having bursitis is a bursitis and not an enthesitis. Similarly, with tendinitis, it may be a secondary lesion to having enthesitis, but only having Doppler activity in the tendon itself is not a sign of enthesitis. Then in relation to the structural changes, I think this paper, though not related to blood flow, is quite interesting from Dennis McGonigal and Richard Wakefield that looked into the presence of the bone erosions. And knowing that we have the insertion of the enthesis in this area here, it was actually shown that in early spondyloarthritis, you could have bone erosions in the superior tuberosity or even in the proximal insertion, but very rarely in the distal insertion. But this was the area where we have the enthesitis, and the orientation of the enthesitis will normally be the traction direction of the tendon involved. So this is an example of a lateral epicondylitis in an inflammatory enthesitis. And just for comparison, this is a lateral epicondylitis in a patient with a sports-related condition. And as you can see, there is a sparing of the 2 millimeter zone between the body of the tendon and what actually constitutes the enthesis. So here we see this is not an inflammatory enthesitis, but a tendon problem, whereas up here we have an inflammatory enthesitis related to SPA. These are more structural changes, so calcifications here, calcification, or perhaps even a bony spur. Here again, bone erosions, and as you can see when we look at the drawing or the picture from the McGonigal paper from 2008, we have bone erosions primarily in the tuberosity and in part of the proximal insertion, but nothing in the distal insertion, and Doppler activity indicating active or hot erosions. In the plantar fascia, we primarily see the thickening, and due to the heel fat pad, it's very difficult to detect Doppler activity in the plantar fascia. We have the normal plantar fascia for comparison here. This is a enthesopathy, a traumatic enthesopathy with a guy taking his dog out for a walk. Dog sees a cat, rushes off, and bam, we have a almost full rupture, or at least part of the enthesis at the lateral epicondyle has disappeared, and very little Doppler activity. What is important to remember is that we can see enthesitis changes in any enthesis in the body. This is the adductor insertion at the symphysis level. So here we only have grayscale changes, but with calcification and hypoechogenicity at the insertion site. Here, this is the insertion of the tensor fascia lata to the crista. This is the normal side. This is the pathological side. We have hypoechogenicity, loss of fibrillar structure. Adding the Doppler, we see that there is increased hyperemia in the area. We can also see Doppler activity in the enthesis of the small fingers. This is the insertion of the extensor tendon at the PIP level. This is at the volar side, also having Doppler activity at the insertion site. However, it is worth remembering that the scoring system was developed for larger enthesis and not the small finger enthesis. So how to use the findings for diagnosing spondyloarthropathy? We know that ultrasound is better than clinical examination for depicting enthesitis changes, both with the Doppler and with the grayscale changes. And especially Doppler activity is a landmark of the inflammatory enthesitis. Hence, we reserve the description only for inflammatory enthesitis. We also know that these changes are more frequently found in the lower limbs rather than the upper extremities. So one of the more famous is Doppler in the enthesis for diagnostic purposes was this 2011. It was a prospective study over 2 years involving 118 patients that had symptoms suggestive of SPA. They had an ultrasound performed of the lower limb and the elbow, and the ultrasonographer was blinded to clinical evaluation. They found that power Doppler activity in at least one enthesis at baseline had a very good predictive value for a final diagnosis of SPA. And here we see that at least one vascularized enthesis had an odds ratio of 14.8 for the diagnosis of SPA. In a not completely similar, but in another study more explorative that came from Dr. Coulada in Spain, they looked at 64 consecutive patients with actual SPA and psoriatic arthritis, to see how frequently involved the enthesis was and how frequently they were inflamed. They had a mean DAS28 of 3.9, a mean DAS-I of 5.6, and the CRP was approximately 10, reflecting moderate to high disease activity. At patient level, Doppler activity was found in at least one enthesis in 52 patients, so in over 80% of the patients. If they used the MASI scoring system, using the OMRAC scoring system, it was slightly lower, but seen in 75%, with no differentiation between actual SPA and psoriatic arthritis. So their conclusion is that it's very common to have Doppler activity when having active actual SPA and psoriatic arthritis. It was actually not quite what we found when we did a study. However, we also had a lower number of patients. But in this study of 21 patients, all with actual SPA initiating adalimumab due to inflammatory activity in their actual disease. They had a BASI of 6.6. They had tender joints of 3.6, but swollen joints were quite low, 0.2, and CRP values slightly lower than in the Spanish study. Here it was 8.5. But they still had moderate to high disease activity in their actual disease. Their peripheral master score was 3.9. In this cohort, where where the inclusion criteria was not having an enthesial involvement, Doppler activity was actually only found in 4 entheses, which in total was 1% of the assessed enthesis. Here, the OMRAC Doppler scoring system and definition was used. What was found in this study was that structural lesions were quite common, and the conclusion was that in this cohort, at least, the inflammatory lesions were relatively rare. It has also been assessed how can we use ultrasound for maybe pre-diagnosing patients that will develop, in this case, psoriatic arthritis. And Professor Naredo looked into a cohort of psoriasis patients with no musculoskeletal symptoms and found subclinical synovitis and enthesopathy. But if you look here, she also found a low number of Doppler activity at enthesial level. So in 10 patients, that is about 7.4%. So in psoriasis patients, we also may be able to detect enthesial Doppler activity, but not in a great number of patients. What will be interesting to see, if there is ever a follow-up of this study, is whether it had any predictive value for later on developing psoriatic arthritis. There are other studies looking into psoriasis patients, and in the Studiani study from 2019, they found a higher number of psoriasis patients having Doppler activity at the enthesis. So instead of 7%, they found 20% having Doppler activity, and they didn't find any in the healthy controls. We looked into a similar thing in a recent study of a psoriasis cohort, both with and without musculoskeletal symptoms, and found Doppler activity at the enthesis level in a slightly lower, but more more related to the Giuliani study of, we found 16%, and we found it most commonly in the lateral epicondyle. So what do we know about Doppler findings in normal enthesis? In this study that was published 3 years ago, 64 subjects were investigated in 4 decades from 20 to 60 years. None of the subjects had signs of tendon and joint disease in the lower limbs, and they had 320 entheses assessed in total. They were only assessed in one leg, and they chose the dominant leg, and they had ultrasound assessed according to the OMRAC definitions for enthesitis, both structural and inflammatory lesions. And they found that 23% of the examined sites had changes, and in 57% of the patients, only one insertion was affected. What was very rare was to see Doppler activity. It was only seen in 4 sites, and the most common lesion was enthesitis, indicating that maybe this is more an age-related finding rather than a pathological finding. There was a weak tendency in the study for more pathology in men, and there was a slight increase in elementary lesions with increasing age, but none of them reached statistical significance. There are also studies indicating that there are a relationship between changes in the enthesis. Here in thickness, there is a relation between the thickness of the enthesis and the weight of the person that is investigated, and similar also an increase in enthesial thickness with age. These are examined for or assess the Achilles tendon and the patellar tendon at the distal and proximal insertion. There was also a poster in 2018 at ACR that looked at the flexor and extensor tendons of the hand and assessing elementary lesions of enthesitis in those, using also the OMRAC definitions. And like the Danish study on the lower limb, the most frequent lesion was enthesitis, most frequently in the DIP, slightly lower in the PIP. And 41 also had concomitant osteophytes. They didn't find any signs of Doppler activity, supporting the notion that Doppler in the enthesis is a pathological finding, whereas enthesiophyte seems to be of less importance. Can we use ultrasound for monitoring treatment? We can. There are several studies showing that Doppler activity is the most sensitive parameter to assess for showing a effect of treatment. The first to be published was from Esperanza Naredo in 2010, and subsequent studies coming out slightly later have shown the same things, that Doppler activity in the enthesis is reduced during treatment with TNF-alpha blocker treatment, both at 3 and 6 months follow-up. As I already mentioned, there are no indications that treatment with a TNF-alpha blocker will affect the structural damage that are seen in the enthesis. So which site should we examine? This is an Italian proposal where they sent out a survey asking other experts' opinion. And what they found to be of interest was obviously other joints and so forth, but looking solely on the enthesis, they wanted to include the Achilles tendon, the patellar ligament with proximal and distal insertion, the quadriceps tendon, the common extensor tendon at the elbow, and the plantar aponeurosis. There was also an interest in including distal insertion of the extensor tendon of the finger. There was also a survey done by the Targeted Ultrasound Initiative group, also asking people which enthesis to evaluate for diagnosis, therapeutic follow-up, and disease state of evaluation. And again, it was the same enthesis, so Achilles tendon, plantar aponeurosis, medial and lateral epicondyle insertion, quadriceps, and patellar ligaments. So though the TUI survey indicated that the medial epicondyle insertion should be included also, there seems to be a general agreement that these tendon insertions are very important. So how to score, and Peter Balin was mentioning this also already. There has been several proposals, the first being the Glasgow ultrasound enthesial scoring system, and then two different ones, including Doppler from Professor D'Agostino's group, and also the MASAI and the SAI coming out of Spain, one with and one without Doppler activity. And so it's a little confusing having so many different ones, and I think it's reflecting that there are also clinically many different enthesitis scoring systems, where maybe masses and leads and sparks are those that are most prevalently used. But the OMERAT group then decided to come up with a consensus-based and validated scoring system using the 4 steps that was previously mentioned, scoring both activity and damage in peripheral joint and large enthesis. And so the Doppler was agreed to be scored 0 to 3, whereas Enthesitis calcification was scored as 1 and only as present absence, erosions as present absent, thickened enthesis as present absent, and hypoechogenicity as present absent. And looking at the Doppler score that came in this paper update from George Brun, then grade 0 is no Doppler signal, grade 1 is less than 2 punctiform Doppler signals, but no confluent signals, grade 2 is 2 to 4 punctiform Doppler signals or 1 confluent Doppler signal, and grade 3 is having more than 4 punctiform signals or more than 1 confluent Doppler signal. And as I mentioned before, it will be interesting to see how this scoring system will be performing in the smaller enthesis of the hand, where there is an increased interest in enthesitis, and that will need to be tested in the future. The scoring system has also been tested in treatment studies, and these data were presented at the ACR Convergence this year from Professor D'Agostino, testing the effect of secukinumab on synovitis and enthesitis, showing changes over a period of 52 weeks. So are there anything to be aware of? Are there any pitfalls when working with perfusion or Doppler activity in the enthesis? And if we look at this as a reminder, the histological image from Professor Mike Benjamin, we remember that the Doppler activity was present just outside and in the body of the tendon, but not are the normal nutrition vessels that may or could be misinterpreted as Doppler activity. These are present around the epicondyle at the patellar ligament, where we have a feeding vessel canal here. They are present near the patellar ligament, but here they are outside. The enthesis is up here, and they are also present near the Achilles tendon, so here near the bony prominence, but not at the enthesis level. So just something to be aware of. So not all Doppler near the enthesis is a sign of pathology. There are also the impact of using NSAID, which is a common drug in SBA patients. So it actually influences the ability to see vascularization by Doppler activity. So it's just something to be aware of. It doesn't eliminate the Doppler completely, but it may affect the amount of Doppler that we see. So for study purposes, either the NSAID should be kept stable or should be stopped before the start of the study. It also affects findings in joints, but this is not the topic of the talk. Also, the position of the joint may impact the Doppler finding in the enthesis. So this is a proximal insertion of the patellar ligament, and the top image shows the amount of Doppler that are seen in the ligament when the knee is fully relaxed and in extended position. With a 15 degrees flexion of the knee, we see a marked reduction in Doppler activity in the same tendon, and with a flexion to 20 degrees, there's hardly any Doppler activity left as compared to the neutral and relaxed state of the tendon. So very important always to examine enthesis on a relaxed joint. There's also the ability of the machine that we use to pick up the Doppler activity. It's very machine dependent. It may also be depending on which modality of the Doppler that we are using. So we should pick the one on the machine we use that is the most sensitive. And then it's important, as we have demonstrated for joints, that the settings are optimized to show slow flow. In the paper from Sterntorp-Petersen that was published in 2015, an optimization of Doppler settings could improve flow information with a mean of 78%, on some machines actually up to 273%. So therefore, this is quite important, and we published a paper in 2008 on how to optimize for machines that are still valid. Also, artifacts can cause misinterpretation near the enthesis, and they may be related either to the machine settings, the surrounding tissue, and the examination setup. So always keep a steady hand and make sure that the patient can keep the joint steady as well. So summarizing what we know about enthesial blood flow, we know that Doppler activity is a landmark of inflammatory enthesitis in SBA, and that Doppler activity is related to final diagnosis of spondyloarthritis. Doppler activity is very rare in healthy controls, indicating that we can use this as a sign of pathology. Doppler activity is sensitive to change during treatment, and we have validated and consensus-based scoring system for enthesitis, both for the Doppler and for structural changes. And then we just need to be aware when assessing Doppler activity of the treatment of the patient, the joint position, and the machine settings. Thank you.
Thank you, Professor Teslev, for the nice talk and presentation. So we have to proceed for the question. Please, if you have any questions, we'll insert it in the chat box. So we have a question regarding the enthesitis, Professor Teslev, how we can differentiate the enthesophyte from osteophyte by ultrasound.
Well, it's definitely difficult, and it is especially difficult when looking at the smaller enthesis around the fingers. So I was very impressed with the abstract at ACR that they could differentiate. But often the enthesophyte is going in the direction of the tendon, and the osteophytes do not. But it is difficult, especially in the smaller joints.
Okay. So another question we have, at which part of the tendon we can measure its thickness in case of enthesitis when using the Massey score?
I'm not so sure about the Massey score. I'm not a great fan of measuring because I think it depends on the pressure of the probe, and it's a little bit more uncertain to me. So I'm more in favor of eyeballing, but if you need to measure that we can do and that we do on the plantar fascia, I would measure the thickest place at the insertion site, and I would go with a rectangular line to the insertion on the bone, though I know that Peter Baylind actually had another proposal.
Yes, yes. But I think also we can rely on the comparing to the normal side that in case we have, so it will be more valuable. I think the more than measure.
I agree. The problem is just when they have pathology on both sides. But I fully agree with you that that is definitely better than measuring, I think.
We have one question for you addressing the cause of enthesitis. Why is continuous trauma cause enthesitis?
Continuous trauma?
Yes. I think the question regarding the biological force that causing repetitive mechanical stress over the enthesis that causing the inflammation, I think.
I don't know why it causes enthesitis, if that was the question, but I could imagine that what we see in patients that don't have inflammatory enthesitis, but an overuse condition is more the traction at the enthesitis, that is the repeated stress that becomes like an irritation. But why it does, I'm not sure I know, or anyone else knows, if that was the question.
This is not related to the topic, actually. One question from me for you, Dr. Sleeve. You know that there is another techniques for assessing the blood flow. You know, there's some machines now with specific small flow detection, like X-flow from Canon, and is it also has. So,
I think and I think GE and Samsung has it too. So we have B-flow and microvascular imaging. Yes. And I think we haven't tested it yet. I think it's definitely very interesting to do on the enthesial level. We have tested it for joints and we're not that impressed. And the flow velocity is more or less in the same range. So I think it's worth exploring to at least gain more knowledge on this. There are studies that I didn't put into the talk that has also used contrast enhancement for enthesis. But I think the money is better spent on having a very good machine with a very good Doppler sensitivity than turning the ultrasound examination into a more invasive procedure. But I fully agree that the new Doppler modalities, because they are basically Doppler modalities, but they work with slightly different aspects, but they would be worth testing for how they perform at the enthesial level, for sure.
Yes, because actually blood flow, and this is very difficult to trace, actually. Very, very uncommon to see the blood flow in most of cases. Okay, that's all the questions that we have, and thanks again, Christophe, to be with us.
I hope you have a wonderful meeting.
Yes.
And take care in these horrible times.
Okay. Okay, thank you.